and gentlemen, first of all, let us pray and praise our God because of His blessing and mercy. We can come together without any obstacle here in healthy condition. It's a great honor for me, Alberta Salsabila, and my partner,
Salsabella,
to be your master of ceremony today on behalf of the Faculty of Medicine, UPN Veteran Jawa Timur. Allow us to convey our sincere gratitude to all of you who have attended today's conference in person and virtually.
we would like to welcome every one of you today
In the first International Seminar Urgency of 2024 with the theme today, Current Update on Medical Sciences.
Before we begin, we would like to extend our warmers to our honorable guest. Good morning and welcome, the Honorable Professor Dr. Insinyur Ahmad Fauzi, Master of Technology Management, Senior Professional Engineer as Director of UPN Veteran Jawa Timur. The Honorable Professor Dr. Hajah Rika Yuli Wulandari, Master of Health Science, PhD, Family Medicine Primary Care Specialist, Subspecialist Family Medicine and Community Medicine as the Dean of Faculty of Medicine, UPN Veteran Jawa Timur. The Honorable Mr. Ali Al-Haddad from McGraw-Hill as the Speaker. The Honorable Professor Tian Shaolis from Zhengzhou University, China as the Speaker.
The Honorable Dr. Chang Chin-tat from Tan Tock Seng Hospital, Singapore as the Speaker. The Honorable Professor Delphak Osiendi, Doctor of Medicine, Doctor of Philosophy from the University of Manchester, United Kingdom as the Speaker. The Honorable Professor Hafiz T. A. Khan, Doctor of Philosophy from the University of West London, UK as the Speaker. The Honorable Dr. Irfani Prashna Paramita, Ophthalmologist from UPN Veteran Jawa Timur, Indonesia as Speaker. And the honorable participants of this morning's seminar. Next, let us read the agenda in this morning as follows. 1. Opening, and will be continued with singing Indonesia Raya as the national anthem, and will be continued with Mars Bela Negara. 3. Opening speech from the TN, Faculty of Medicine, UPN Veteran Jawa Timur. 4. The opening speech, also opening ceremony from the Rector of UPN Veteran Jawa Timur. 5. Entering the main agenda by mini-seminar. And 6. Coffee break.
7 is followed by the presentation of material by the first speakers. 8 and will be continued by the presentation of material by the second speakers. 9th is the presentation of material by the third speaker. 10th, the presentation of material by the fourth speaker. 11th, the presentation of material by the fifth speakers. And the last agenda for today is the closing ceremony.
Before we start our agenda, let's recite dua that will be led by Mr. Marianto.
Assalamualaikum warahmatullahi wabarakatuh. Bapak Ibu, saya pimpin doa secara Islam bagi Bapak Ibu bisa menyesuaikan dengan kepercayaan masing-masing. A'udzubillahi minasyaitonirrajim. Bismillahirrahmanirrahim. Allahumma inna nas'aluka salamatan fid din wa afiyatan fil jasad wa iyatan fil ilmi wa barakatan fil rizqi wa taubatan qabla al-maut. Allahumma hawi sakaratil maut wa najita minan nar wa alfa'inal kisab. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina adzabannar. Wassallallahu ala sayyidina mursalin walhamdulillahi rabbil alamin. Assalamualaikum warahmatullahi wabarakatuh.
Well, ladies and gentlemen, the next agenda is namely singing the national anthem Indonesia Raya, which will be continued by singing the Mars Bela Negara song.
Attendees are welcome to stand. Attendees are welcome to sit back. The next agenda is the opening speech from the DN Faculty of Medicine UPN Veteran Jawa Timur to Professor Dr. Hajarika Yuli Wulandari, Magister Health of Science, Doctor of Philosophy, Family Medicine and Primary Care, Specialist Doctor, Subspecialist in Family-Oriented Medical Care. The time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua. Very good morning. We extend our warmest welcome to all the guests who joining us today to attend the International Seminar of Faculty of Medicine, Universitas Pembangunan Nasional Veteran Jawa Timur, Urgency 2024, Recent and General Update in Emergency with Hybrid Mode. I also would like to extend our gratitude to Honorable Rector of UPN Veteran Jawa Timur, Profesor Dr. Insinyur Haji Ahmad Fauzi, MMT, IPU. Also to Vice Rector 1, Profesor Wisnu Hidayah, Vice Rector 2, Dr. Sukenda. Also the special recognition to Mr. Ali Al-Haddad, the Senior International Business Director of McGraw-Hill Professional, to Mr. Kelvin Ong, the Regional Sales Director, APAC McGraw-Hill Professional, and also to Ibu Lucia Sari, the Business Manager Indonesia of McGraw-Hill Professional. Our respected speakers, Professor Dr. Tian Xiao Li, Zhengzhou University, China, Dr. Chong Ching Tet from Tan Tock Seng Hospital, Singapore, Professor Delphak Osiandi, MD PhD from the University of Manchester, UK, Professor Hafiz T.A. Khan, PhD from University of West London, UK, and also our adjunct professor of the Faculty of Medicine UPN Veteran Jawa Timur. Also Dr. Irfani, ophthalmologist, the lecturer of Department of Ophthalmology, Faculty of Medicine, UPN Veteran Jawa Timur. The Honorable of Representative of Faculty of Medicine in Indonesia, from Universitas Gajah Mada, Dr. Widya, from Universitas Airlangga, Dr. Hermanto, from Universitas Brawijaya, Dr. Dwirtno, from Universitas Diponegoro, Dr. Latifah, Universitas Ciputra, Dr. Areta, Universitas Nahdlatul Ulama Surabaya, attended by the Dean, Dr. Handayani, Universitas Islam Negeri Malang, Dr. Yosi, Universitas Negeri Surabaya, attended by the Dean, Dr. Endang, Universitas Muhammadiyah Surabaya, Dr. Anas and Dr. Laili, Universitas Islam Negeri Syarif Hidayatullah Jakarta, Dr. Marita, Universitas Kristen Duta Wacana, Dr. Haryo, Universitas Islam Bandung, Dr. Mia and Dr. Mira, and from Universitas Negeri Malang, Dr. Erianto. Also our respected participants from Partners Hospital, Dr. Intan Sudarmadi, the Director of RSUD M. Saleh Probolinggo, also Dr. Utoyo and all the team. From RSUD Sidoarjo Barat, from Public Health Services or Puskesmas in Surabaya, and also our beautiful and high quality midwives in Surabaya, and high school students, and the lecturer, the employee, and the students of Faculty of Medicine, UPN Veteran Jawa Timur. First of all, let us thank God, the Almighty, who has given His grace and guidance so that the International Seminar of Faculty of Medicine, UPN Veteran Jawa Timur, Urgency 2024, with hybrid mode, offline, here, and also by online using Zoom and through YouTube, can be held successfully. Again, I express my highest gratitude and appreciation to all speakers, the presenters, and attendants. I believe that this seminar will be the source of innovative ideas, concepts, and breakthrough in the field of medicine, especially related to emergency cases and disaster medicine. This seminar will not be well organized without the support of various parties, including the sponsors, McGraw-Hill, and the contributions from all the participants. Therefore, again, I want to express my highest gratitude. We also collaborate with Bali Medical Journal as an international journal and the Indonesian Biomedical Journal as the Scopus Index International Journal for selected papers to be published. I especially thank the organizing committees led by Dr. Aninda Anestesis, Dr. Irma, and all the team members for their hard work, perseverance, and patience in preparing and organizing this seminar so that it can go well, smoothly, and successful. Today, we have two events. The first is the international seminar that is held in this room, attended approximately by 250 people offline in this room, and about 3,000 people go through YouTube and by Zoom, and in total 5,200 people join Learning Management System of Ministry of Health. Therefore, the participants, the attendance of this seminar will be granted with 10 credit points from Ministry of Health. The second event is VIP meeting attended by representative of 15 Faculty of Medicine throughout Indonesia to discuss about the future evolution of medical education, organized by a collaboration between McGraw-Hill and Faculty of Medicine UPN Veteran Jawa Timur. As your information, today's event actually is a part of celebration of our first anniversary of Faculty of Medicine UPN Veteran Jawa Timur that established on 30 May last year. We firstly organized the hybrid mode of international seminar, but in fact, we have been organizing webinar at either national or international level every month since March until upcoming November this year, with different specialties topic each month. For example, in the last March, the international webinar is about innovation for global healthcare with the speaker from Canada, UK, Malaysia, India, and Indonesia. And on April, we have webinar about update on reproductive health. On May last month, we have essential in surgery and emergency. And today's seminar about urgency. Next month on July, we are going to organize webinar about current innovative in pediatrics. On August, about management strategies on respiratory emergency. And on September, about what's new in dermatology. On October, about neurology and psychiatry update. And on November, about emergency in internal medicine. Therefore, besides attending today's seminar, I also would like to invite all of you to attend our upcoming webinar. Finally, through this seminar, let us extend the network and cooperation among all faculty of medicine, among all stakeholders, also with other professionals. As today's, beside medical doctor, also this seminar attended by midwife, nurse, nutritionist, and also medical student and high school student in Surabaya. So please enjoy the seminar, recent and general update in emergency of Faculty of Medicine, Universitas Pembangunan Nasional Veteran Jawa Timur. Billahi taufik walhidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Before continuing with our next agenda, we would like to invite the Rector of UPN Veteran Jawa Timur for the opening speech, also opening ceremony. Please welcome Professor Dr. Insinyur Ahmad Fauzi, MMT IPU. The time is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning, greeting Vice Rector of UPN Veteran Jawa Timur, the Dean of Faculty of Medicine UPN Veteran Jawa Timur, Profesor Rika Yuliwandari, PhD, Master Ali Al-Haddad, and team from Macro Hill. Thank you for coming. The speaker today webinar, whom I respect, Professor Tian Shaoli from Yangzhou University, China, Dr. Chong Ching Tet from Tan Tock Seng Hospital, Singapore, Professor Delphak Osendi, PhD from the University of Manchester, UK, Professor Hafid Khan, PhD from the University of West London, UK, Dr. Irvani Pratnya Parimita from UPN Veteran Jawa Timur, all doctor from universities and hospital, thank you for coming in campus UPN Veteran Jawa Timur. Thank you for joining, but actually I wish you all could come because we have many kind of food here in Surabaya. And I have prepared them all. Maybe one day, I hope soon. And all participants, good morning and a warm welcome to the first International Seminar Urgency 2024. It is a great honor for me to open this important event organized by the Faculty of Medicine UPN Veteran Jawa Timur. The seminar is not only part of the celebration for the Faculty of Medicine first anniversary, but also a sign of our dedication to advancing medical science and contributing to global health improvement. The theme of the seminar, Current Update on Medical Science, is very relevant today. With rapid growth in science and technology in healthcare, it is essential to have platforms like this, where we can share ideas, opinion, and research findings. We hope that the discussion and insights shared during the seminar will drive innovation, address challenges, and bring positive change to global health services. By gaining the knowledge in disease diagnosis, treatment, and medical technology, we aim to help Indonesia compete in the health sector and build long-term collaboration in research. I want to thank all the speakers, participants, and organizers who have worked hard to make this event possible. Your effort are truly appreciated, and I am confident the seminar will be a great success. Let's make the most of this opportunity to learn, collaborate, and innovate. Together, we can make significant steps in medical science and contribute to a healthier future for anyone. Thank you and wish you all a successful and inspiring seminar. By Bismillahirrahmanirrahim, I open this seminar in here. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Ahmad Fauzi, for the speech. So, ladies and gentlemen,
Distinguished guests, ladies and gentlemen, we will now proceed to the main agenda, which will be a mini-seminar with the topic, The Role of McGraw-Hill Access Platform in Medical Education. And we are pleased to invite the speakers for this first session. So, ladies and gentlemen, please welcome our amazing speaker, Mr. Ali Al-Haddad. Let's give a warm round of applause.
Assalamu alaikum wa rahmatullahi wa barakatuh. Sorry. Thank you everybody for joining us both in person and virtually. And also thank you for allowing McGraw-Hill and myself the chance to be here with you today. So today's session, I will briefly talk about what we as McGraw-Hill do within the medical education space. So for those of you that don't know, McGraw-Hill Education has been around for over 100 years. When we started off as a publishing company. So we were publishing textbooks that many of you probably use till today. Books like Harrison's Principles of Internal Medicine, Fuster's The Heart, Fitzpatrick, and many other great titles that you utilize throughout your medical education, both while studying as well as while you teach. Now, as the world changed, we as an organization evolved. And about 20 years ago, we entered the realm of digital medical education. So all our resources became available digitally around the world. And we started off with the focus of ebooks. And then as we expanded, our focus on our platforms began to increase. So today I'll speak to you a little bit about what that focus has looked like, where the world has moved with regards to medical education, and how McGraw-Hill is supporting that change. So my name is Ali Al-Haddad. I am based in Dubai. I work for McGraw-Hill Education. I am the senior director for our international business. So I look after everything outside the US. And I've been to Indonesia multiple times now, and I visit all customers around the world. And it's my pleasure again today to be here with you. So I want to share with you some of the things that we have found as McGraw-Hill. So over the last year or 2 years, we've been conducting a lot of research around the world. Research to help us understand how students today are studying, as well as how faculty can help students. So the first thing that I would say is that we as McGraw-Hill are proud to work with medical universities around the world. Right? So this is enabling our research. We have customers in pretty much every country that speaks English in the world. We support them in a variety of ways, and we continue to expand our footprint. Now, what we also offer is world-class learning content, as I said before. So our content is really focused on medical education, and we support the entire spectrum within the medical education space. We do this through interactive learning resources. So our learning resources, as I said before, started off as ebooks, and over the years has expanded into a variety of multimodal learning resources. And our reach is global. So we provide resources that not just support students within a specific continent, but our resources are really relevant to students all over the world. So before I continue, I'll play a short video that tells you a little bit about our main resource, Access Medicine. If we could play the video, please.
Elevate your teaching with McGraw-Hill Access, world-renowned medical content available anytime, anywhere via the web version as well as the mobile app. Access offers interactive resources from the best medical minds for all teaching and learning approaches, empowering lifelong learning for the medics of tomorrow. Find trusted high-yield content in a world-class teaching and learning platform that integrates easily with your learning management system and puts students at the heart of education. With thousands of resources at your fingertips, Smart Search enables you to filter your results across topics, book titles or media, finding what you need in seconds. You can even customize your content by saving to favorites, organizing collections or folders, and annotating to build your own digital information bank. Now, let's take a closer look at some of the resources. In books, you will find an extensive selection of world-leading medical textbooks, such as Harrison's Principles of Internal Medicine, Goodman and Gilman's The Pharmacological Basis of Therapeutics, Tintinelli's Emergency Medicine, Williams' Obstetrics, and Fuster and Hurst's The Heart, to name a few. For certain books, you can even explore the review questions and the cases associated with the content and save them in your profile. You can also use the Read Speaker tool. Set chapters as reading assignments and encourage critical thinking and debate to bring your teaching to life. And when you're looking for quick answers to complex issues, go to the Quick References section for summaries and synopses often used by students when in a real-life medical setting. You will also find thousands of practical resources in our multimedia section with interactive tools such as 3D imagery, podcasts, and a vast video collection including physical examinations, procedural videos, online lectures, and animations, providing valuable resources which you can embed into your teaching. Educators also love our real-life cases, which enhances students' learning experience by making it more interactive, practical, and engaging. The detailed cases include key takeaways and suggested reading, and the interactive platform enables students to test their own diagnoses of real-world patient problems that they will face in their future medical careers. Access provides an updated and comprehensive integrated drug database that allows a quick search of dosages, indications, and adverse effects of generic and brand name medications. Access also offers a wide range of study tools to support your students, including quizzes and flashcards to help them grasp complex concepts and be prepared for classes and exams. At McGraw-Hill, we're passionate about medical education. Our editorial team, comprised of world-leading medical professionals and educators, continually update our platforms with the latest authoritative medical content. which is why Access is used and trusted by leading medical institutions in over 118 countries across the world. Teach your way to empower lifelong learning with McGraw-Hill's Access. Explore our medical resources at mhmedical.com or download the McGraw-Hill Access app today.
So that was just a little short video about some of our resources that we offer. And why I wanted to show this video is, number one, I wanted to highlight the fact that we have a variety of resources that allow faculty and students to learn in different ways based on how they like to understand. The other thing that is important to highlight is that we cover the whole spectrum of the medical education space. So everything that includes physiotherapy, pharmacy, and everything under the medicine umbrella. Now, we obviously, as you saw in the video, work with customers throughout the world, 118 countries, and we work with some of the biggest brands and biggest universities. So some of these are contributors and authors to our content, whilst others are our users, and we get continuous feedback from them. So you see on the stage some of the names of some of our customers from around the world. Now, as I said earlier, we've been conducting some research, and I think this may be something that will be really relevant to a lot of you today. And within that research, we tried to understand, what does the medical student persona look like? So we spoke to students and faculty from around the world to understand a little bit about what is important to medical students. What we understood is that medical students have a specific set of requirements and goals. Their number one goal has become to pass the license or board exam. This is their number one goal, right? Every medical student today is really focused on everything they do so they pass the exam. This is not obviously something that used to be. In the past, medical students wanted to actually learn about medicine, understand medicine in depth. Now we're finding the trend is more around, how do I pass my exam? The other thing is that students are really focused on preparing for rotations, right? So the knowledge they get in the university, they try to make sure they understand how that applies to their rotations or their residency program. The next thing is that students need to work on their own to find their own fundamental and foundational knowledge. So as many universities around the world are moving to problem-based learning approaches, students have started to find that they need to go out on their own and find the knowledge that they need for the basic sciences and the simpler courses. And then the next point is that there is the increased competition around getting into the specialization that they want, right? So it goes back to the first point. They need to maximize their score in their exam so they can get into the best specialization. Now, the last 3 points are really important. What we found is that students want to be able to get content in granular formats, so very small, bite-sized pieces of learning. Students also want to be able to read less. They don't want to be reading as much because of social media. They want to watch more. Okay, so we need to be able to work closer with students so that we're giving them content in the way that they want to absorb it. So, what are their behaviors? Around the world, and it changes from some country to country, but globally around the world, we're seeing that students are now more focused on self-directed learning. So they want to learn on their own in the way that they feel is best, and typically within their environment of their peers. Students are also more visual learners. As I said, they don't want to read, they want to see, they want to watch. And students are also more mobile heavy, so they want to have everything at their fingertips on their phone rather than sitting behind a laptop or reading through a book. We're also seeing that students love the idea of applied learning so that they can actually utilize more cases and problem-based learning because they're quickly applying the concepts and theories that they are learning on their own. And then obviously students are relying more on social media for getting their information, and this can be very dangerous, right? Because not everything on social media is real and is accurate, especially if you're trying to be a doctor. And then students have also really into multimodal learning. They don't want to learn as passive learners. They don't want to learn as one type of way. They want to be able to learn in a variety of ways. And they love to have instant and engaging feedback. Today's world, students don't have patience. So they need to know instantly, how am I doing? What do I need to do? How can I improve? So with all of this in mind and all of this research, we have started to adapt and change the way that we as McGraw-Hill present our solutions and encourage faculty, universities, physicians to utilize a different learning methodology that is going to capture the attention of students. So as you see here, one of my favorite quotes from one of the students was, "I don't have time to read through 30 pages. Just tell me what I should know. Tell me what I should learn." And so, what do we believe are some of the drivers of this change? Why do we see some of this change happening? The first thing is that there is too much information to memorize, right? Students don't have the time or the patience to memorize all of this information. So what are they doing? They're trying to find high yield, high summarized content. Very important for the student. Just give it to me in a summarized format. I will quickly learn it. The next point is that I want to learn through case-based, team-based, problem-based learning. I want to be able to learn in an environment of discussion and applying a lot of the theory that I learn. And I want my education to be active. I don't want to be passive. I don't want to be sitting in a lecture room listening. I want to be involved. I want to give my opinion. I want to be able to discuss what I am learning and what I feel. And it's less teacher-centered education, right? So the teachers and the faculty are very important, but students don't want them to be at the center. Students want to use them as a mentor, as a guide, and as a helper. Students want to do their own work. They want to have their own opinions, their own discussions, and be able to trust their teachers and lecturers to get the information is accurate and get their feedback. Students want to have answers to specific problems and topics. As I said, they want them quickly and they want them at their fingertips. They want to be a visual learner, so they want video-based resources, and we're finding video-based resources and case-based resources are becoming the highest used resources on our platform, more than even textbooks as we look at data globally. And as I said, they want to be able to collaborate, work in a group, learn from their peers, and they want to be able to utilize self-assessment practice questions, right? They want to have as many questions as they can on their own to practice the content they're learning to ensure that what they are learning is accurate and get that instant feedback. So, what does this mean for us as McGraw-Hill? When a customer has the complete package of all the McGraw-Hill resources, their students will have access to all of this, right? So in the past, you'll see that the focus and students really wanted to utilize our book titles. So throughout our resources, we give access to more than 1,100 medical titles, some of the best books that you will ever use as a medical student, right? But then this is now expanding. So now our students are utilizing all of these other resources. So we give them access to more than 7,000 clinical cases. We give access to more than 100,000 self-assessment questions, more than 13,000 multimedia learning resources, more than 3,000 anatomy modules, more than 200,000 images, and more than 130 audio podcasts. These podcasts in the last few years have had more than 2 million downloads around the world. And I think in Indonesia, if you think about all the traffic that people sit in, to be able to listen to a podcast while you're stuck in traffic will really maximize your time. And these are the ways that students want to learn. So we give access to universities so that they can assign these to their students, or students can go on their own and find the resources that they want. So how do we best use this, right? I spoke about students wanting multimodal resources and wanting to learn at the way that they feel is best. So you'll notice that we have cases through our case files collection. We have 3 types of cases. We have cases that are more for self-directed learning. So they're simple cases where students can go on their own, go through any type of topic, search it, have that case, get the findings, the diagnosis, and understand with an explanation. Very simple, students can do them on their own. Then we have the second and third type of cases that are more complex. So these cases support a case-based learning approach, or the third type, they will support a problem-based learning approach. These cases are typically multidisciplinary, very complex, and they cannot be done on their own. They need to be done in a tutor environment, 10 to 12 students or 6 to 12 students with a faculty member discussing the case in detail. The cases support a spiral curriculum so that you're not just covering histology or biochemistry, but you're including clinical topics, and everything that you need within that block of learning is covered in this case through multiple sessions. So one case can span 2 or 3 sessions. And so this is becoming really, really popular around the world as universities move to problem-based learning. One of the biggest problems that faculty have is, how do I create such a complex case? I need to bring in faculty from different specializations, different knowledge, and create a multidisciplinary case. Then this case has to be uniform, standardized, with the same kind of learning objectives, and our students need to have the same experience. So what we do is we provide these cases to our customers through our Teaching Cases platform so that they don't have to have this headache. The next thing is our quick references. As I said, students want to have everything quick at the touch of their hands. So through our new mobile app, students are able to go through things like QMDT for quick reference medical treatment and diagnosis, and find out a quick answer to something that they are reading about. Then we have infographics. So infographics are short one-pagers that a lot of students use as they're revising for exams. Right? They've spent time, they've learned the detail. Now, 2 days, 3 days, 1 week before my exam, I want to just quickly remind myself about a topic. So we have a lot of infographics that students can have on their phone, and it's one page, and it gives them all the key points that they need to remember. Really, really important for that last-minute cramming before an exam. And we have, obviously, as I said, the podcasts. These podcasts are recorded by our authors and editors of some of our big books, like Harrison's, on specific topics. And you can listen to them anywhere through our application, wherever you are, download them, listen to them. And then, as I said, we have audio and video clips. We have a variety of videos that range from procedural videos, they range from lectures, they range from short form videos, conceptual videos, animations. Everything is available for the students to utilize. And then we have, as I said, 100,000 plus self-study questions. So these are not meant for assessment. These are questions that are meant for students to go, get a question, multiple choice, put an answer, and get instant feedback. Right? It's not supposed to be for grading. It's just for them to keep practicing what they're learning, and obviously our fundamental textbook chapters. So how do we put all of this together? As a faculty member, you may think to yourself, how do I use this? There's a lot here, and what's the best way? So as we move to technology, the approach that you utilize will really cover 3 things. So you'll be able to have, through this approach, cover things pedagogically. You can ensure that the content is accurate, and you need to ensure that you have set up the technology properly, right? So that this approach really works. So how does that work? Obviously, we give you the authoritative content, so you can use that for the content piece. We give instructors access to resources like PowerPoint slides, solution manuals, and other things that they may want to utilize. We give, as I said, the clinical decision support tools. We give the multi-learning resources, and we give you the case-based learning resources, and then we give the study tools, which are flashcards. So all of these combined, if you use them in the way that aligns to your curriculum, your students will be able to have a variety of ways to learn in the way that they like and in a way that is controlled. So what is the best way to deliver this to your student? I think it's really important that we understand that students want to be told a lot of the times what information they need to learn, right? They want to be told that by their faculty member, because it is their faculty members that they trust. So what is happening around the world is that we're seeing this, what we call a shadow curriculum, on platforms like Anki and others that are open source, where students are going out on their own and actually going through their own curriculum that is being suggested by their peers from around the world and learning through open source content. The problem with this is that, like learning through Google or Wikipedia, you don't know if this content is really accurate, authoritative, up to date, or aligned to what you want to be them to learn in Indonesia. Because again, even medicine has different approaches depending on what you want to teach them. In the US or in the UK, they will treat symptoms and treat problems differently. So if students are learning on their own, then they may think they are right, but it may not be aligned to what you want them to learn, and in turn they may not perform well. So to overcome that, our advice is that you utilize these resources through the learning management system that you have. So whether it be the 4 that I've listed here, Blackboard, Moodle, Canvas, Desire to Learn, or your own learning management system that you have built yourself, and encapsulate all of these resources within that system. And we can help you do that, right? So here's an example from one of our customers. You'll see in the screenshot where they sat and they said, okay, I want your help and advice on how do I put this into my learning management system. I want my students to read a little bit of the book. I want to give them 5 videos for this learning objective. I want to give them a case. I want to give them some self-assessment questions, and then I want to give them a variety of flashcards and infographics. So all of those links you can put into the learning management system, so all you have to do is tell your student, hey, go to the learning management system, go to this course, in learning objective 1, everything you need to pass the exam is there. Don't go anywhere else, don't waste your time. I've made it the way you like it, with different varieties of learning and different styles. So this is really important because this will capture the attention of your student, and it will ensure that your students are learning the things that you want them to learn. And through this as well, you're able to facilitate your problem-based learning cases, ensure that you're using the right cases to the topics that you want. And obviously, students can access this on their mobile as well as through their laptop. So these are just some of the best practices that we're seeing around the world, and these are the ways that we're supporting customers as well as students. And basically, the last thing that I wanted to just mention is that to make this successful, a year ago, we launched our brand new Access app. So this app, we invested a lot of money in it. It is really new and sleek and a great user interface for students. It is available for free to any customer of ours. You're able, through this QR code, or if you just search on the App Store, at McGraw-Hill Access, you're able to download the app both as faculty and as student, and you can have access to everything through your mobile. The app has offline functionality so that you can save things offline if you don't have internet, and listen, watch, read, and it has the online functionality as well. So with that, I just want to say thank you for your time. Thank you for listening. Thank you for giving us the opportunity to be here. Thank you for UPN for organizing such a great event. And I look forward to discussing anything with anyone that's interested further as we continue the day. Thank you.
Thank you so much for the insightful information, Mr. Ali Al-Haddad. And please remain on the stage for our group photo session. So as we approach the conclusion of this session, we would like to invite
the rector, vice rector, and all of the lecturer together on the stage for a group photo session.
Dimohon kepada setiap perwakilan dari Fakultas Kedokteran untuk maju ke depan foto bersama, kemudian kepada Direktur Rumah Sakit Umum Daerah Probolinggo untuk berfoto bersama, dan juga perwakilan dari fakultas yang lain. Once again, thank you for Mr. Ali Al-Haddad for your time. And once again, please round applause to our speakers for their valuable knowledge.
So ladies and gentlemen, before we move along to the second session of the seminar, we will take a short break. Please enjoy the coffee break menu that provided on the fifth floor while enjoying the music performance in this room, and please note that the next session will start after 10 minutes. Thank you. Bagi para pengunjung, dipersilakan untuk menikmati menu coffee break yang berada di lantai 5 dan dapat dikonsumsi di ruangan ini sembari menonton penampilan dari teman-teman mahasiswa Fakultas Kedokteran. Terima kasih.
Dan mohon diingat untuk acara akan dimulai lagi setelah 10 menit. Terima kasih. For the attendance, especially to the Dean of Faculty of Medicine, UPN Veteran Jawa Timur, the Dean of Faculty of UPN, another faculty of UPN Veteran Jawa Timur, and the Dean of Faculty of Medicine from other university.
Also, the representative of RSUD Dr. Muhammad Saleh Probolinggo, the representative of RSUD Provinsi Jawa Timur Surabaya, the representative of RSUD Grati Kabupaten Pasuruan, the representative of RSUD Sidoarjo Barat, also the representative of RSUD Dr. Muhammad Suwandi Surabaya, the representative of Puskesmas Kalirungkut, the representative of Puskesmas Medokan Ayu, the representative of Puskesmas Tenggilis, Puskesmas Gunung Anyar, Puskesmas Klampis Ngasem, Puskesmas Keputi, Puskesmas Menur, Puskesmas Jagir, Puskesmas Jemur Sari, also Puskesmas Sidoarjo.
Entering the first session is in this presentation is the material by the first speakers with the topic, the treatment and management of an acute stroke. We are pleased to invite the moderator for this third session. So, ladies and gentlemen, please welcome our amazing moderator, Dr. Tiamaya Afrita, Forensic and Medical Legal Specialist. Let's give a warm round of applause. Dr. Tiamaya, the floor is yours.
Okay, thank you for the Master of Ceremony for today's. We'll proceed by sitting here. And thank you, everyone. I welcome you to our first seminar, international seminar held by Medical Faculty of Universitas Pembangunan Veteran Jawa Timur. And today, we are going to present a couple of things. And firstly, I'm going to welcome you all, the guests and also the participants of this seminar today. And I am Tiamaya Afrita, will be the moderator of our first lecture session, which will be presented by our astounding speaker, Professor Tianxiao Li from Zhengzhou University, China, with the chosen topic of application of one-stop multimodal imaging platform in treatment of acute stroke, and which we know is a very interesting topic, since stroke itself is one of the rising illness in the world. Yeah. Before we begin the presentations, allow me to read the curriculum vitae of Professor Lee, which one of the experts in today's topic. We can see from his CV that most of his work and study were addressing the stroke issues. Professor Lee was graduated from Peking University, China, and from his long list of working experience, his latest will be Henan Profession People's Hospital in Zhengzhou, China. And okay. Before we proceed, I need to inform you all, for the participant, that the Prof. Lee wouldn't be able to join us live here in Zoom meeting, but rather will presenting his topic using pre-recorded videos, and it implies that there will be no discussion for this session. We apologize in that regard, but without any further ado, may the committee please play the lecturing video of Professor Lee.
Good morning. Thank you for the invitation of the chairman. It's my great honor to have the opportunity to speak at this conference. The topic today is application of one-stop multimodal imaging platform in the treatment of acute stroke in my hospital. Stroke has become the first cause of death among Chinese residents, among which ischemic stroke accounts for more than 80%. The average annual incidence of stroke in China increased by 8.7% per year. and the risk of stroke in Chinese life is as high as 39.3%. It's the highest in the world. Without effective measures, there will be 31 million stroke patients in China by 2030. The prevention and treatment situation is very serious. We all know time is brilliant in acute stroke treatment. 1 minute's delay will cause 1.9 million neuron loss. Within 6 to 8 hours of onset, advancing reperfusion by 30 minutes can lead to good outcomes for 10 to 15% of patients. However, in clinical practice, pre-hospital delay and in-hospital delay are still common problems. Delays are evident even in international renowned RCT studies. Traditional green channel treatment process is from emergency center to CT or MRI catheterization room, while the optimized process bypasses the emergency center and goes directly to the CT room before reaching the catheterization room for flight plan DSA. Furthermore, a more advanced one-stop solution is achieved through a multimodal imaging platform, including CT, DSA, and MRI. First reported case of direct transport to the catheterization lab is reported from Germany in 2017, greatly shortened DPT and DRT. Another study about direct transport to the catheterization lab show one-stop mode accelerate the process and improve the outcome. Direct transport to the catheterization lab significantly reduced in-hospital delays and increased the rate of good outcomes. One study of comparative study of transport to the emergency department, CT room, and catheterization lab also shows prognostic improvements. DTAS reduces admission to recanalization time by 40 to 70 minutes and increases good prognosis by 15 to 30% compared to DTER. In 2019, a retrospective analysis in German about direct transfer to the catheterization laboratory versus the CT laboratory, significant reduction in in-hospital delays. A single-center retrospective comparative study showed that the one-stop model was an independent predictor of good prognosis compared to the transit CT room model 3.75. In 2020, Stroke Journal published a German randomized control comparing direct transfer to catheterization lab modality with transfer to CT modality, which is excluding general anesthesia intubation cases. The results show no difference between two groups in good outcomes. So the study is early terminated. It unproven transfer to catheterization lab one-stop advantage. Comparing to flated one-stop mode, multimodal one-stop mode is fast and precise with obvious advantages. In 2019, our hospital actively participated in the construction of the National Stroke Prevention and Control System and built an air, ground, and network integrated stroke treatment system in Henan province. The 1-hour treatment cycle shortened the pre-hospital transport time. The mobile stroke unit was used before the hospital. and the hospital built the first multimodal imaging stroke treatment platform in China. We also held a grand opening ceremony. This is a one-stop multimodal imaging platform for stroke care. The platform comes from Siemens officially launched the first CT-MR DSA integration in Asia Pacific in 2018, which include a 64-row multi-slice CT, 3.0 MRI, and DSA RTSQ double C arm. This is an operational demonstration of our one-stop multimodal imaging platform. The traditional mode goes through multiple procedures. Patients have to be transferred to the emergency department, laboratory, CT room, catheter room, and other different places for examination and treatment, which delays a lot of time. The traditional green channel modes usually take more than 2 hours. The new one-stop model integrates all of the above steps, significantly reducing the time to imaging assessment and rescue treatment. Different from other hospitals, all the medical staff in our stroke treatment center, including neurology, imaging, interventional, and intensive care units, are from the same team of Henan Provincial Cerebral Vascular Disease Hospital, so the efficiency is very high. All team members are online at the same time, and it is very convenient to use WeChat group to quickly conduct early warning and case discussion. This is a flow chart of acute stroke treatment in our hospital, which is very clear and fast from out of hospital transport, in-hospital assessment, and first aid and in-hospital triage. This is a typical case of rapid treatment after our process optimization. The system also has many other image evaluation sequences and patterns, and can use AI to provide diagnostic advice, which is more conducive to accelerate treatment of acute cerebral infarction. It also creates a new model of one-stop stroke diagnosis and treatment. This is embolization patients. We bypassed the emergency and went directly to a one-stop shop with an admission to puncture time DPT of only 29 minutes. This is out of hospital referral direct one-stop. The door to recolonization time just 54 minutes. The patient was sent from public emergency system 120 to one-stop for treatment, bypassing emergency department and the radiology department. One-stop multimodality imaging play an important role in precise pre-operation identification and evaluation. The use of one-stop imaging makes post-operative assessment possible. It allows for rapid post-operative outcome assessment. One-stop multimodal imaging (MRI) with AI volume measurement is convenient, rapid, and precise in mechanical embolectomy screening. This is a patient with embolism beyond the time window. After multimodal imaging evaluation, The core infarct was only 15 milliliter, and the mechanical thrombectomy could be performed according to Dawn standards, so the patient was treated. One-stop multimodal imaging can be used in rapid efficacy assessment. This patient is a typical example. Rapid imaging assessment before and after thrombolysis demonstrated the blood reperfusion was successful despite poor clinical outcomes. If it is needed, immediate post-operative reperfusion assessment can be achieved. One-stop multimodal imaging is more suitable for intelligent information tool applications, such as rapid, OLEA, and so on. Unfortunately, the outbreak of COVID-19 occurs shortly after our one-stop multimodal imaging stroke center was put into use. But we still insisted on continuous thrombolytic and mechanical thrombectomy therapy for acute stroke, and conducted a comparison study with the traditional mode and obtained very meaningful research results. The article was published in Frontier in Neurology. DPT get a significant reduction in admission to puncture time of approximately 45 minutes. For patients admitted to the hospital at early stage of the disease, less than 6 hours, prognosis of patients can be improved, suggesting that early pre-hospital identification and rapid transportation are still the main problems, and the efficiency of the thrombectomy in primary hospitals is higher. Blue bar is one-stop mode, and the orange bar is traditional. To sum up, the advantages of one-stop multimodal imaging stroke care platform are as follows. Its seamless link of imaging assessment and thrombectomy minimize DPT. Patients within 6 hours of onset have better clinical outcomes. Critically ill patients needs more than 6. Patients with extra time windows have the greatest value of accurate assessment. Continuity of assessment after recanalization is possible. Disadvantages are as follows. Expensive equipment, high manpower costs, equipment and systems need further optimization. Over-reliance on multimodal assessment may prolong treatment time. Good prognosis remains highly dependent on early pre-hospital stroke recognition and rapid transport. So, my lecture is finished. Thank you for your patience.
Thank you for Professor Lee for amazing and very inspiring lecture that has been given. If I may conclude on what was being discussed earlier is that stroke being #1 cause of death in China is being handled very professionally and very efficiently by Chinese doctors and government. Continuous research and updates are being implemented in hopes of the better results of treating stroke patients, and one of the proposed update management was using one-stop multimodal imaging platform to cut short from lengthy process of stroke diagnosis and management, which in the end intend to increase the life expectancy and the recovery of stroke patients. This is a truly inspiring work which we can hope will be implemented in Indonesia as well in order to increase the likelihood of better recovery and better quality of life of stroke patient. Finally, we'll reach the end of first lecture session, and I guess now we can proceed to the second lecture with the topic of emergency treatment of ocular chemical burn, which now happening more and more common due to the nature of the trauma itself, which can be happen in a working environment or as an assault. This topic will be presented by Dr. Irfani Prajnamita, specialist ocular. Before we proceed, allow me to read our speaker CV first. So Dr. Irfani is having a lot of experience in regards of surgical training in eye surgery, and also the LASIK training, and also the focal emulsions. There are a lot of training that she's been getting. And for the working experience, she have a long list of working experience as well. And currently, she is working at Lucas Hospital and also Mitrawaru Hospital as ophthalmologist. Now, without any further ado, let's give it up to Dr. Irfani Prajnamita. Thank you.
Good morning. My topic today is about the management and treatment of the ocular chemical injuries. Okay, as we know that chemical burns represent potentially blinding ocular injuries and constitute a true ocular emergency requiring immediate assessment and also the initiation of treatment. And the recent studies put the ocular chemical burns at the 11.5 to 22.1% of all ocular traumas, with alkali injury occurs more frequently than acid injuries. And these injuries occurs most often among the age group from 20 to 40 years and young men at greatest risk. And actually, these ocular chemical injuries can occur under diverse circumstances in such a varied location as the home, the workplace, and school. And also, these injuries are common in industrial chemical laboratories, in machine factories, in agriculture, among laborers, also in construction workers, and frequently reported from the cleaning and sanitizing crews. And these are the list of the common causes of the acid and alkali injuries, where the sulfuric acid is the common cause responsible for the acid injuries that can be found in the car batteries. Sulfuric acid can be found in bleach and refrigerant, hydrofluoric acid in glass polishing and mineral refining, acetic acid in vinegar and glacial acetic acid, also hydrochloric acid in swimming pools. Then ammonia is the common cause for the alkali burns that can be found in cleaning agents, fertilizer, also refrigerants, potassium hydroxide in caustic potash, lye in drain cleaners, in airbags, also magnesium hydroxide in fireworks, sparklers, and flares. Lime, also the cause of the alkali burns that can be found in plaster, cement, and whitewash. And now we talk about the types of the ocular chemical burns. The first is acid burns. Acid have lower than normal pH values of the human eye, which is 7.4, and then the acid substances can penetrate into the tissue protein and then creating a barrier to a further ocular penetration. So due to this fact, then acid burns tend to be less severe than alkali burns. The second is alkali burns. The alkali burns can cause corneal damage by the pH change and also the ulceration, also scarring. Then the alkali substances are lipophilic and hydrophilic, so they can penetrate the eye more rapidly than acids. The alkali substances can quickly deposit within the tissue of the ocular surface and then causing saponification reaction. And the damaged tissue secrete proteolytic enzymes as the part of the inflammation reaction, and this leads to further damage. And furthermore, the alkali substances can also penetrate into the anterior chamber, causing pH change of the aqueous humor, and then the damage to the corneal and conjunctival epithelium too. The damage can be so severe as the damage to the pluripotent limbal stem cells, and this leads to the limbal stem cell deficiency and leads to corneal opacification and corneal neovascularization. The damage to the ciliary body and trabecular meshwork, also accumulation of the inflammatory debris within trabecular meshwork, also causing IOP rise. Then the loss of goblet cells and also the conjunctival inflammation can leave the ocular surface prone to dryness, and then the damage to the conjunctiva can cause extensive scarring, and then lid malposition may be present due to the simple variant formation, and this leads to cicatricial entropion and cicatricial extropion. Now, the classification of the ocular chemical burns. The first is Roper-Hall classification. The Roper-Hall classification was largely based on the degree of the corneal haze and also the limbal involvement. And then JAWA proposed a new classification scheme based on the clock hour of the limbal involvement as well as the percentage of the conjunctival involvement. The important thing is to note the amount of the limbal, corneal, and also conjunctival involvement at the time of the initial injury, and then to document the changes in the examination as the patient followed. This is the picture of the marbleized epithelium. Marbleized appearance. Yeah, that one, the opaque one, with no vascularization in the conjunctiva and also in sclera. And then the second picture is 9 clock hours of marbleized limbus and sclera, indicating intense ischemia, and then stromal edema and striae, also positive fluorescent staining, indicating corneal epithelial defects after the injury. Now we talk about the clinical course of the ocular chemical burns. The first is immediate phase. Immediate phase begins the moment a chemical agent comes in contact with the ocular surface. And then the second is acute phase. During this time, the tissue reestablishing the superficial protective layer of the corneal epithelium, and that serves as a protective barrier. The third is early reparative phase. This is the transition period of the ocular healing and also the acute inflammation. Stromal scarring and also corneal ulceration tends to occur in this phase. The last is late reparative phase. This phase is characterized by the completion of healing and also with good visual prognosis and also the complication with guarded visual prognosis. Now we jump to the management and treatment of the ocular chemical burn at the pre-hospital setting. The very first step after the exposure of the ocular surface with the chemical agent is continuous irrigation, because prompt irrigation takes priority over looking for the chemical composition or waiting for specific fluids. So just start the irrigation with any available clean solution as soon as possible. For the position to do the irrigation, should be seated upright or laying down, and then the head should be tilted to the affected side. So if the right eye is affected one, so the head should be tilted to the right side, pulled away from the non-affected eye to prevent the injury from the fellow eye. And then the irrigating solution should be from nasal to lateral. Then after the patient transferred to the hospital, before irrigation, we should measure the pH with litmus strip or pH strip in both eyes, even when one eye is affected, because the other eye may serve as a control. And then we can instill the anesthetic drops. The anesthetic drops here is important as it relieves pain, relieves blephar spasm, also allow patient to open the eye. We can use eye speculum or Morgan lens to keep the eye open, or manually open the eye, or using bandage like in this picture. This is Morgan lens. This is Morgan lens. The Morgan lens, the lens is attached with the IV line, so it will be easier to do the irrigation. The other important step is to remove any chemical particles from the ocular surface with forceps or with cotton tip swabs. And then we can continue copious irrigation with isotonic solution or physiologically equivalent isotonic solutions such as lactate ringers, balanced salt solution, or normal saline for 30 minutes. And then we can stop and wait for 5 minutes. Then we can reassess the pH again with litmus paper. If the pH is not neutral, then we can continue the irrigation for 30 minutes or longer. And once the stable normal pH is achieved, then we can reassess on slit lamp for the details and document the severity according to the classification. And in acute and early reparative phase, the important thing is to control the inflammation reaction with a topical corticosteroid for at least 7 days. Topical corticosteroids have been shown to reduce the release of pro-inflammatory cytokines, suppress the infiltration of neutrophils, modulate the production of matrix metalloproteinases, also reduce the risk of corneal opacity. However, topical corticosteroids can also inhibit the corneal wound healing and also the collagen reformation. So in the presence of non-healing epithelial defects, then steroids should be tapered after 10 to 14 days because prolonged treatment has been associated with corneal ulcers and corneal melting. We can use prednisolone acetate 1% or dexamethasone 0.1%. Then, once the acute inflammation is controlled, the next step is to facilitate the healing process of the ocular surface with wide array of medical treatments, includes preservative-free artificial tears. Artificial tears here will reduce the chance of the persistent epithelial defects and also the recurrent epithelial erosions. Then we also need antibiotics. The broad-spectrum antibiotics can be used for the prophylaxis because of the load of the common soft flora. We can use erythromycin ointment 4 times daily to provide ocular lubrication and prevent superinfection. Or we can use tetracycline 250 milligrams 4 times daily to prevent enzymatic proteolysis of corneal stroma, or doxycycline 100 milligrams 2 times a day to reduce the effects of matrix metalloproteinases, which can degrade the collagen type 1 and type 3. And then for the ascorbic acid, have been shown to reduce collagen degradation, promote collagen synthesis, reduce corneal ulceration and perforation. We can use topical 10% eye drops every hour, or orally with 2 grams daily, can be divided into 4 doses. And don't forget that the measurement of the intraocular pressure is mandatory because the IOP may rise due to the disruption of the trabecular meshwork. So if the elevated IOP is detected, then initiation of anti-glaucoma medications will be prudent. The mydriatic and cycloplegic agents here are needed to treat the iridocyclitis and also prevent or break synegia, because in the acute inflammation of intraocularly, then maybe present the posterior synegia or glaucoma secondary glaucoma. We can use topical atropine 1% or cyclopentolate. While platelet-rich plasma eye drops have been shown to be rich in growth factors, also lead to faster epithelialization. Now we talk about the surgical treatments. Although surgical management is reserved for the higher grades, but at any stage of the ocular chemical burns, maybe surgical intervention may be recommended. The first is debridement of the necrotic tissue. As we know that necrotic tissue can be a source of the inflammation and also inhibit the re-epithelialization, so it will be prudent to remove the devitalized tissue. The next is amniotic membrane transplantation. This is amniotic membrane. Amniotic membrane may be transplanted as a single or multiple layer. It may be suture or sutureless or attached by adhesive tissue onto the overlying corneal surface and then retaining it in place with symbol-varon ring or conformer ring. Amniotic membrane have been shown to improve patient comfort by reduction of the eyelid friction, express TGF-beta1 and epidermal growth factor, also prevent symbol-varon formation, prevent scarring and neovascularization, also alleviate inflammation. There's a new delivery devices like Procera. This is Procera. Procera is a cryopreserved amniotic membrane that clip into a dual ring system, so it allows rapid and also sutureless placement of the amniotic membrane. Then in cases with severe chemical burns, anterior segment necrosis may be present due to the loss of the limbal vascular blood supply. And in this case, then the advancement of the conjunctiva and tendons to the limbus or tenonplasty can be employed. Tenonplasty have been shown to provide the ischemic limbus with healthy vascular connection tissue, prevent corneoscleral ulceration and melting, also facilitate re-epithelialization. And then the next surgery treatment is keratoplasty. Keratoplasty or corneal transplantation is considered for those with visually significant stromal scar or stromal perforation. And when multiple keratoplasty procedures have failed, then we can use keratoprosthesis. Yeah, the picture with the suture is a penetrating keratoplasty, and on the left side is keratoprosthesis. Then if the mild ocular chemical burns with partial limbal stem cell deficiency and conjunctivalization of the cornea without fibrovascular panis has occurred, then sequential sector conjunctival epitheliectomy or SSCE can be employed. This is the abnormal epithelium. This is the abnormal. The A picture is the abnormal epithelium that with a late fluorescent staining and seen to covering the visual axis. The B picture is the abnormal epithelium then remove, leaving off the limbus and then allow complete healing, as seen as the picture in the C picture, and with bright shiny laser. And then the last is limbal stem cell transplantation. Much of the damage following chemical injuries result from limbal ischemia and the subsequent loss of stem cells capable of repopulating the corneal epithelium. Then limbal stem cell transplantation have been employed to replace this critical group of cells and is an option when corneal conjunctivalization is total or center involving. Both techniques, simple limbal epithelial transplantation and cultivated limbal epithelial cell transplantation, are acceptable. And then finally, the summary of the recommended treatment according to the Roper Hall classification. For grade 1, we can use topical antibiotic ointment with erythromycin or similar 4 times a day. Prednisolone acetate 1% up 4 times a day, preservative-free artificial tears as needed. And if there's a pain, then consider a short-acting cycloplegic like cyclopentolate 3 times a day. For grade 2, we can use topical antibiotic drop like fluoroquinolone 4 times a day, prednisolone acetate 1% hourly while awake for the first 7 to 10 days. And don't forget to consider tapering the steroid if the epithelium has not healed by 10 to 14 days. Then long-acting cycloplegic like atropine can be used with oral vitamin C 2 grams 4 times a day, doxycycline 100 milligrams twice a day, and also sodium ascorbate drops 10% hourly while awake, preservative-free artificial tears as needed, and also debridement of the necrotic epithelium. Grade 3 as for grade 2 with considering the amniotic membrane transplantation or procara. For grade 4 as for grade 2 and 3 with early surgery is usually necessary in this grade. Thank you.
Okay. Thank you, Dr. Fani, for the amazing presentations. And now, if I may, I think we can proceed to discussion session here. We invited the guests and participants who have any questions may raise their hands, or if you follow the seminar by online, please write your questions in the meeting chat. And if there are any questions from the audience, okay. There is one question, Dr. Fani. May the committee please give the guest. Thank you. This will be, can you, okay, is there any microphones or she needs to, oh, okay. Oh, okay, please may come forward and you may use one of the microphones over here and please state the questions. Okay.
Okay, first of all, I want to introduce myself. My name is Leonesia Sukmawinata, and I am from student of Faculty of Medicine UPN Veteran Jawa Timur. And then I want to ask your question about, can we use tap water for the irrigation if there is no clean water available? And do you have recommendation for the irrigation solution? Thank you.
Answer the questions right now. Are you wanting a question there? Okay.
Okay, thank you for the question.
Okay, is there any questions there, or would you mind to sit on the front seat, or would you want to come back? Oh, you want to come back there? Okay, it's okay. Thank you.
Okay, thank you for the question. Actually, there are a wide variety of the irrigating solution that we can use for the irrigation. And tap water is actually widely available, but it's not sterile and is actually hypotonic into the corneal stroma. So it can lead water influx into the cornea and causing corneal edema, also further diffusion of the corrosive materials into the cornea. So the hypertonic solution is preferable because it can increase the osmotic pressure and dissolve the corrosive materials out of the cornea. For the irrigating solution, the isotonic solution, we can use lactated ringers, balanced salt solution, normal saline with bicarbonate or phosphate buffer solution. And for the hypertonic solution, we can use diphotrin. Diphotrin is great for reduce the pH change in the aqueous humor, and also paraffin solution and borate buffer solution. However, delaying the irrigation for waiting for the specific fluid to become available is not recommended. So just start the irrigation as soon as possible with any available clean solution, even it drinking water or even tap water. Then transfer to the hospital and do the second irrigation until the pH is neutral.
Okay, thank you, Dr. Fani, for the amazing answers, but I worry that we may only have time for one question for now. So I have to say my apologies to those the question hasn't been read or hasn't been discussed yet. And with the end of our Q&A sessions now, I think this is the end of our second topic as well. And please give applause to Dr. Irfani Prajnamita for the amazing presentations. And I'm Tia Maya Afrita. Wish to say farewell because my job is finished for now, and see you in the future events. And I'll give it back to the host. Thank you so much.
Thank you, Professor Tian Shaoli, Dr. Irfani, and Dr. Tia Maya. So, ladies and gentlemen, once again, please round applause to our second and third speakers, also our moderator for the interesting presentation.
Ladies and gentlemen, as we are starting the fourth session with the topic Emergency Management of Intracranial Hemorrhage, it's my pleasure to invite our amazing moderator to the stage. Please welcome Dr. Fitri Septianti Sumardi, specialist in anesthesiology and intensive care, subspecialist in neuroanesthesia, Master of Health. Let's give a warm round of applause.
Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Today is maybe the third topic for today. So we can invite Dr. Chong from Zoom. Dr. Chong, are you here?
Good morning, Dr. Fitri. Can you hear me?
Dr. Chong?
Yes.
Yes, I see you. Would you mind to open your camera?
Yes, I'm opening now. Can you see me?
No. I only can hear you.
Okay, hold on. Let me try again.
Operator, would you mind to open a camera for Dr. Chong?
Hello.
Oh, I see you now. Hello. Good morning.
Yes.
Good morning, Dr. Chong.
It's
very, yeah, it's my great honor that you can join me and us today here for the topic that emergency in intracranial. Maybe before, first for all is I would like to thank all here who stand until now with us. And then maybe before we start, Dr. Chong, would you mind if I read your CV? Because
yes. And
yes.
can you please let me share screen?
Yeah. Okay.
So I can share the presentation.
Dr. Chong is one of maybe one of my role model and mentor for me. So it's once again thank you so much, Dr. Chong. Dr. Chong is a specialist accredited with the Ministry of Health Singapore in anesthesiology in 2008 and intensive care medicine 2013. Personally, he is a senior consultant and neuroanesthesiologist, neuroanesthesia service, and a head of the department in Tan Tock Seng Hospital, Tan Tock Seng National Health Group, Singapore. His his subspecialty interest in neuroanesthesia and neurocritical care. Dr. Chong also teaches into medical school, one in National University of Singapore and Nanyang Technological University. Currently also Dr. Chong is a serving on the Asia Society of Neuroanesthesia and Critical Care, and a former president for the Singapore Society anesthesiologist. So, Dr. Chong, would you mind to open the camera again, because the floor is yours now.
Can you share screen, please, Dr. Fitri? Can you see my screen?
Yes, I see you well, and your voice also. You can start.
Can you see the slide?
Yes, Dr. Chong, yes, okay. It's well.
Okay, I start now.
Just relax, Dr. Chong. The floor is yours as time as you want.
Dr. Fitri, I already started the video. Can you hear? Can you see the screen?
Yes, it's well.
Intracerebral hemorrhage, can you see the first screen?
Yes.
Okay.
All of us can see yours
yes.
Video.
First slide, okay, starting again.
I cannot hear your voice. I'm sorry, Dr. Chong.
You cannot hear?
Yeah, can you explain to us here?
Okay, let me start the video one more time.
Yeah.
Because the lecture, can you hear the lecture?
Yes.
You can? Okay.
Yes, your voice is great here.
No, but can you hear my lecture? Dr. Fitri? Dr. Fitri? Dr. Fitri?
Hello? Yes, Dr. Chong. The floor is yours and the time is yours also.
I am playing my video on the screen. Can you see now?
Yes, I see it well, but it's without sound, without your...
Let me try again. Okay. Let me try, okay. Can you hear?
Hello? I'm sorry, Dr. Chong, we cannot hear your voice. Maybe you can turn off the video and try with the slide.
Dr. Fitri, can you ask the host to make the video louder, please?
Okay.
If you cannot hear, sorry.
Would you mind to, Pak, bisa dikerasin nggak suaranya? Di fullin.
I will try.
Yeah, it's a full.
Okay, hold on, please. I try again.
We are waiting.
start?
No, I cannot see.
Can you hear Dr. Fitri?
No, it's more worse than before because now we cannot see anything.
Oh. Okay, 1 minute.
Would you mind if try with the slide?
Okay.
Maybe for your information, today participant around.
Fitri.
No.
No, can you see the slide?
Yes.
Can you see the? Okay, any noise, any voice?
No. Maybe with your voice is better.
Okay, then can you ask the host to open my slide on her screen? I will use my voice.
Oke. Minta slide-nya. Minta dibukain slide-nya.
Okay. Okay, I will start. Okay, thank you, Dr. Fitri. Sorry for the technical problems.
No, it's okay.
But because of the time,
yeah,
I will go ahead and start. So firstly, I want to thank you for the invitation to the urgency seminar. Thank you so much. So I will start by talking about intracerebral hemorrhage. What is the definition? The definition is that it is spontaneous, non-traumatic bleeding into the parenchyma of the brain. So I won't be focusing on traumatic intracerebral hemorrhage. I will just be talking on spontaneous ICH. So ICH causes about 10 to 15% of the incidence of strokes. So the rest of the strokes are ischemic strokes, whereas about 10 to 15% of the strokes are intracerebral hemorrhage. This causes a mortality of about 35 to 50%, and the patients can pass away in the first 2 days in about 50% of the cases. So what are the frequent causes? Number one, chronic hypertension forms the majority of the causes, about 60% of the cases. Other than that, we also have other causes such as cerebral amyloid angiopathy, or if the patient is taking medication like warfarin or antiplatelet medication such as aspirin, or if the patient has got other vascular ailments like arteriovenous that can raise blood pressure, for example, cocaine or amphetamine. Next slide, please. Okay, so this is a slide that shows the right basal ganglia ICH. As you can see, there is also extension into the ventricles, which causes intraventricular hemorrhage, also known as IVH. Next slide. Okay, so the management will be based primarily on the ENLS algorithm. ENLS is the Emergency Neurologic Life Support, quite similar to ACLS. ACLS is cardiac, emergency cardiac life support, but now we have emergency neuro life support. So what happens is that at the top, when your patient first present to the emergency department or to the ICU, you will suspect intracerebral hemorrhage. And of course, the first thing is always ABC, airway, breathing, circulation. So you want to check whether the patient has got adequate airway. If the airway is adequate, then you can proceed to a non-contrast CT brain or CT head. If the airway is not adequate, then of course you have to do a rapid sequence intubation to protect and secure the airway. After you have done the non-contrast CT head, then you can diagnose whether the patient has got ICH. If there is no ICH, then maybe the cause of the low GCS is due to ischemic stroke or coma of other causes. So if there is ICH, then what should we do? Number one, we should get a brief medical and medication history. Two is we want to control the blood pressure. Quickly try to bring the blood pressure to 140 to 180 range of systolic. Next, we want to do hemostasis. For example, if the patient is on warfarin and the INR is quite high, maybe more than 1.5, then we want to give anticoagulant reversal. If the patient is on aspirin or other antiplatelet, then we want to consider giving a platelet transfusion. After we have secured the blood pressure and hemostasis therapy, want to consider surgery. So this one, the neurosurgeon will make the final decision. They will offer surgery, especially if it's life-threatening deterioration or if the ICH is in the cerebellum. Next, consider a EVD, which is a ventricular drain, especially if there is any evidence of raised ICP or if the GCS is less than 9. We want to aim a goal of ICP less than 22 or CPP more than 60. After that, we can characterize ICH. And if your center is not a neuro center, then maybe you want to consider transferring to a specialty neurology ICU care. Next slide, please. Okay, so for the first hour, it is critical. So we will complete the blood count with full blood count with the platelet count and the PT-PTT. We will do head imaging results, try to check whether there's hematoma size and the location and whether there's any intraventricular extension. We want to characterize the Glasgow Coma score and evaluate the ICH score. And what should we do in the first hour? Always try to reverse any coagulopathy, aim to lower the international normalized ratio to less than 1.4. We also want to correct the blood pressure aggressively, bring the blood pressure between 140 to 180 mmHg, refer to a neurosurgeon for any surgical hematoma evacuation, and then, of course, manage the airway and the ventilation. Next slide, please. Okay, alternatively, you can also take reference from the Critical Care Journal instead of ENLS to manage the spontaneous intracranial hemorrhage. Next slide. So this is a similar algorithm to the management. You have number one, the medical stabilization to prevent hematoma expansion. And then of course, you have the imaging, as I mentioned, and then refer to surgeon for any intervention and prevention of secondary brain injury, okay, and then subsequently stabilization. Next slide. So maybe give you a case example of number one. This is a 78-year-old man with hypertension, atrial fibrillation, and mild dementia. He presents with an onset of slurred speech and right-sided weakness at 8 a.m. And he presents to the emergency department 15 minutes later at 8:50 a.m. So the Glasgow Coma scale now is 13 E4 V4 M5, and the blood pressure is 172/85. So what should we do for such a case? Next slide. Okay, so it is important in the first hour that we try to minimize any secondary brain injury. So what can go wrong in the first hour? Of course, as I mentioned, if the airway is not patent, then this can lead to airway compromise. So we want to prevent any hypoxemia or hypercarbia that can lead to secondary brain injury. Next is we want to make sure that there won't be any herniation or brainstem compression. We also want to avoid any hematoma expansion if, as for example, if the blood pressure is very high. Okay, and other secondary brain injuries such as seizure, fever, hyper or hyperglycemia should also be prevented. So this is the concept of the first golden hour. to avoid secondary brain injury. Next slide. So after we have managed to secure the airway, then as I mentioned, go for the non-contrast CT head. Sometimes there is no intracranial bleeding, and then the underlying diagnosis could be just acute ischemic stroke or other causes of coma, and we will manage these accordingly. However, if there's intracranial hemorrhage, then the following management continues. Next slide. So you can see that is frontal intracranial hemorrhage. Next slide. So what we will do next is get a brief medication and medical history. So our history should focus on any history of hypertension, diabetes mellitus, any history of atrial fibrillation or heart disease, any medications like antiplatelet agent or anticoagulant, and take a social history in case the patient is taking any cigarette smoking or any drug abuse. So for this case, patient is on warfarin for atrial fibrillation. Next slide. Okay, and so we will give medication to reverse the warfarin. Another thing is the blood pressure control. So the patient blood pressure is 172/85. So for the time being, it is still considered within acceptable range, because according to the ENLS protocol, we want to keep the range between 140 to 180 mmHg. So if let's say the blood pressure is more than 180, then we will base our principles for rapid control of blood pressure using a drug that has rapid onset and easy titratability. For example, the bitalol or nicardipine infusion. In my center, we try to avoid nitroprusside or GTN because they are causing a cerebral vasodilation. Next slide. So blood pressure control is very critical. This control, if done very proactively, will limit any hematoma growth, because hematoma growth usually occurs within the first hour of presentation. And if there's any hematoma expansion, this will lead to very poor prognosis. Okay, and studies such as the INTERACT-2 trial have clearly defined that we want to aim for blood pressure 140 to 180. Okay, not too high, because too high will cause intracranial hematoma expansion, but not too low also, because less than 180, this can lead to increased extracranial complications, for example, acute renal impairment. Next slide. So, for example, if the patient comes with a SPP systolic blood pressure more than 200 systolic, then we want to give medication like, for example, intravenous labetalol or intravenous nicardipine to try to aim to bring down the blood pressure. Okay, so essentially aim blood pressure between 140 systolic to 180 systolic. In between, it will be acceptable. Next slide. Next is hemostasis. For example, in this patient, the INR is quite high because patient was on warfarin. So what we will do is we'll give reversal agent. Next slide. To achieve hemostasis, we use prothrombin complex concentrates in our center. So this is preferred to FFP because intravenous PCC as compared to FFP is faster onset, and it can reverse the warfarin very fast. And the PCC dose is adjusted based on the patient's INR. After giving the PCC or the prothrombin complex concentrate, we will then give vitamin K 10 mg IV for sustained reversal for the next 3 days. So this table lists the dose of the PCC depending on the patient's presenting INR because he is on warfarin. Next slide. Okay, what if there is other agent on board other than warfarin? For example, if the patient is on heparin, then the reversal agent is protamine. If the patient is on aspirin or other antiplatelet agent, then we will consider DDAVP or even platelet transfusion, especially if going for a neurosurgical procedure. If the patient is on NOACs or novel oral anticoagulant like rivaroxaban or apixaban, then we will consider also PCC is possible, or a specific antagonist like annexinate alpha. Okay, if the patient is on direct thrombin inhibitors like dabigatran, then we will use idarucizumab, which is a monoclonal antibody reversal agent. Next slide. Okay, what about the role of surgery? So we will refer to neurosurgeon if there's any life-threatening deterioration, or if the cerebellar hematoma is more than 3 cm in diameter. So the surgeon will usually consider surgery if there is mass effect due to the ICH, which will cause a drop in GCS. Okay, so this would be considered a life-saving measure. There is also some role of minimally invasive aspiration technique, which I'll talk a bit in a short while. As for cerebral ICH, it can also be considered if there's declining neurologic examination, or if the size is more than 3 cm, or if there's any hydrocephalus or compressive effect on the brainstem. Next slide. So consider EVD if there is a drop in the GCS, okay, and it will be recommended if there's any hydrocephalus or if there's any large mass effect. Next slide. So, okay, this is a supratentorial ICH. You can see that this is in the frontal lobe. So what we can do is we can characterize the ICH. We can measure the volume of the, okay, so in this case, the volume will be a component of A, which is the largest diameter, 4.2 cm, versus B, and the cross-sectional perpendicular cuts, which is 2.8 cm, and the clot thickness, which is 2.5 cm. So by the formula, the volume of this clot is 14.7 cc. Next slide. Next slide, please. Yes, and then you will also want to see whether there's active contrast extravasation. So this would be what we call a spot sign. If there's any extra position of the contrast, meaning the spot sign, it means that there is still active bleeding and there is high risk that the hematoma will still continue to expand further. Next slide. So for this case one, we will score our ICH, and based on the GCS, the ICH volume, whether there's any presence of intraventricular hemorrhage, okay, whether it is supratentorial and the patient's age, we can score the ICH. So in this case, the ICH score is 1. Next slide. So what is the significance of the ICH? This is associated with an increased risk of mortality and increased or decreased risk of poor outcome. So this is a good method for communicating disease severity. Next slide. After that, we want to do the transfer to the neurocritical care unit, okay, because sometimes the patient may come to a center that doesn't have any neurocritical care facility, so we will do the urgent transfer after stabilization and life salvage surgery. So we will communicate the age, the GCS, the hematoma characteristics, the CT finding and spot sign, okay, and whether airway, the patient is already intubated and ventilated, what is the treatment instituted like blood pressure, medicine, and any coagulation reversal agent given, medication, and the surgery done for the patient. Next slide. So, okay, case 2 is a case of a 52-year-old lady. She has no medical history. She presents with sudden headache, vomiting, and slurred speech. She is on aspirin, not warfarin. She is on aspirin for ischemic heart disease, and the GCS is 15. Next slide. So based on the communication, we want to know as per first case, the airway status, the breathing, the blood pressure, okay, and other demographic parameters like the age and the gender, the GCS, any signs and symptoms, and the brief medication and medical history for this patient, such as a previous stroke, any blood thinner, etc. Next slide. Okay, so in this case, there is suspicion of intracerebral hemorrhage. So this time round, this is an infratentorial hemorrhage because the bleeding is in the cerebellum as compared to the first, which is tentorial. Next slide. So again, this patient blood pressure now is very high compared to the first case. So the blood pressure is 205 over 120, which is very dangerously high. So for this case, we will give labetalol or IV carbine to try to lower the blood pressure to 140 or between 140 to 180. In this case, for hemostasis, a patient is not on warfarin, so no need to give a prothrombin complex. However, because patient is on aspirin, you can consider giving platelet transfusion or DDAVP. And the surgeon will decide whether there's any indication for surgery, especially if there's any life-threatening deterioration, or if the hematoma in the cerebellum is more than 3 cm. If there's deterioration due to expanding cerebral hematoma, then this is an indication for surgery, meaning hematoma evacuation. Next slide. So again, we can characterize the infratentorial hemorrhage. We can do the assessment of the volume of the ICH. So again, based on the CT scan, we know that A is 2.8 cm, panic diameter is 2.6, okay, and the cuts is 3 cm. So the volume is a 10.9 cc. Okay, there is no H, okay, and the GCS score is now 6. Next slide. So again, we do ICH scoring. So as opposed to the first case, this case, the total score is 2. Next slide. Next slide. Yes, so for this case, so again, we will reassess the age, the GCS, the hematoma volume and location, any CT findings like intraventricular extension, hydrocephalus or spot sign, and then the ICH score, the air rhesus, and the blood pressure, and any coagulation abnormality or any reversal agent given. Next slide. So this is an example of a neurosurgical intervention. So the patient has got a basal ganglia lead due to high blood pressure. Okay, so what the surgeon can do is they can do a conventional craniectomy and they can evacuate the hematoma. Next slide. So the ENLS also mentioned minimally invasive evacuation. So usually minimally invasive evacuation, like we do in our center, we will do endoscopic evacuation of the hematoma. So you can see on the lower column, the collateral damage is less, there is less edema, and you can put back the bone, the skull bone after the surgery quite fast. Okay, next slide. So this is an example of minimally invasive neurosurgery. So they will do endoscopic evacuation of the hematoma by the neurosurgeon. Okay, next slide. So you can see also the pathway. They will evacuate the hematoma endoscopically. So this is considered minimally invasive neurosurgery. Next slide. So what is the summary? So I just want to share some clinical pearls, and that is hematoma expansion usually occurs within the first few hours, within the first 6 to 12 hours in most of the patient. We should try to look for any spot sign because the spot sign will indicate active bleeding. Okay, then these patients will be at high risk of hematoma expansion. We can use the ICH score as a means to communicate. Okay, although it is not so good as a predictor of neurologic outcome, but it is a good way to communicate about the patient. Admission to ICU with the neurocritical care facility, specialized neurocritical care facility, is associated with improved ICH outcome. Next is you want to lower the blood pressure to 140/80 as a target range to prevent hematoma expansion. And then urgent coagulopathy reversal, for example, with prothrombin complex, concentrate or specific reversal antidote, or if patient is going for surgery, then platelet transfusion is important to minimize hematoma expansion. Okay, currently, if the patient does not improve after surgery, then you want to consider subclinical seizure. So in this case, we will give a seizure prophylaxis. Next slide. Yeah, so thank you. Thanks, Dr. Fitri. So sorry, the video cannot play.
Don't be sorry, it's excellent lecture. Maybe now is for Q&A session. The rule is maybe we limit question around 3 questions from online or offline. The rule first, maybe the questioner is mention name and institution, and the second, if maybe the question or there is a suggestion or experience can share here, but maybe short and clearly. Dr. Utoyo, ada pertanyaan? Dari Zoom? YouTube? Nggak ada. Okay. Dr. Chong, maybe I will ask, maybe it's for the our student medical school here, maybe. So how much usually you reduce BP? Around 20 or 30%, or like you mentioned in your lecture, it's like around 220 or 240.
Okay, so maybe can you please show the slide again? It is in mentioned there. If the patient present with high blood pressure, more than 200, is it Dr. Fitri?
Yes,
more
yes, because maybe if if we reduce it too fast, maybe it will be not too good results.
Yes, can you please show my slide again? Under blood pressure, I have made a note about if the blood pressure is very high, then if you lower too fast, it can cause other non-cranial impairment. Maybe can the host show my slide?
Slide, which number, Dr. Chong?
On blood pressure? Before this? Some more? Yeah. More? Some more?
But we are here not, okay. This one?
This go. Yes, some more. Under blood pressure. More, go back. More, please. More. Okay, yes, that's one. That one, stop. Forward, please, forward. Forward. Okay, this one, yes. Okay, so you can see if the patient has got no evidence of ICP, so generally we want to target between 140 to 180. Okay, but if there is evidence of raised ICP, then if you lower it too fast, for example, if the blood pressure is already 200, then usually we want to be maybe less aggressive. We will try to get 190 instead. Okay, that means you have to do it slowly first. Don't lower to 140, 180 if the blood pressure is above 200 or if there is evidence of raised ICP. So regarding your question, Dr. Fitri,
Yes.
in this case, if the patient is systolic blood pressure more than 200, then I won't drop to 140 so fast. Okay, I will slowly bring down first to 190, especially if there's evidence of a raised intracranial pressure. Because if you drop the SBP too fast, then the CPP will not be enough. Because CPP is also dependent on the systolic BP.
Yes.
So firstly, I will reduce it to 190 first.
Okay.
Yeah, then after that
What
stable,
time?
I will try
Around
to bring it down within the first hour.
first hour. Okay.
Yes, then after that, when you reach 190, then slowly you can afterwards bring down to 140 to 180. Yeah, so this is the example of your case because the patient came with 200 systolic blood pressure. But if the patient came with systolic only about 180 to less than 200, then within the first hour, you can try to bring down to 140, 180.
Okay, thank you, Dr.
So it
Chang.
depends on the presenting blood pressure, if it's more than 200, and it depends on whether there's evidence of raised intracranial pressure. So to answer specifically your case, because you mentioned your patient is 200 systolic,
Yes.
then within the first hour, I will try to bring down to 190 first. No need to bring down so fast. Then after it is 190, then the next hour, you can bring down to 140, 180.
Oh, so it's like a
Systolic.
slow, and then fast.
Yes.
Yes.
No, stepwise.
Yeah.
Not fast, but stepwise, one step
Okay.
at a time. First, you bring down to less than 190. If blood pressure is more to start with. Yeah, then after that, you bring down to 140 to 180.
140, around 140.
So first hour, bring down to 180.
Yes.
So the next hour, you can bring down to the target range of 140 to 180.
Okay. So it's like a.
So do a stepwise. Yes, because your patient come in with systolic more than 200, which is a very high. But if the patient come in less than 200, then you can bring down to 140, 180 straight away in the first hour.
Okay. Thank you so much. Maybe another question? No? Okay. One more, Dr. Chong. I'm sorry for me again. What usually anticoagulant you use for these cases? For like
Reversal?
anticoagulant. What you in your hospital usually use?
For reversal?
What?
Anticoagulant reversal? Is it for reversal of the anticoagulant?
Oh. Pardon, Dr. Chong, I maybe you can repeat
The
again.
patient in with, if patient come in because of warfarin, then you first with prothrombin complex concentrate. If the patient with come in with dabigatran, you can use the monoclonal antibody reversal, idarosizumab. If the patient comes with other NOACs, you can also use PCC, prothrombin complex concentrate. If the patient comes in because bleeding due to aspirin or Plavix and then going for surgery, you can give platelet transfusion.
Okay.
Yeah, so as your question, what is the reversal agent?
Pardon?
No, so the reversal agent will depend on what is the medication
Okay,
that
I
the
see.
patient is on.
I see now. I'm sorry. Okay, Dr. Chong. Any other question? No, maybe because of time also. Before your closing statement, maybe I will tell about the take-home message for your lecture
Yes.
today. Correction if I am wrong. So one is like anamnesis and physical examination is the most important for the future management. The second is like if you find a patient with unconscious, maybe the first is like principle is like ABCD neuroanesthesia. Correct, Dr. Chong?
Yeah. All right. This is especially for medical student, very
Yes.
important.
Yes.
A, B, C, airway, breathing, circulation, then D, disability, which is the neurologic examination and the CT scan. Yeah.
Okay.
So A, B, C, D.
D.
Airway, breathing.
Breathing.
If not breathing and airway not secured, then we do rapid sequence intubation. Then after that, C is circulation. If blood pressure is very high, you can give medication to bring down the blood pressure.
Yes.
Then D is for disability, which is a GCS, and the non-contrast CT brain, urgent, after you stabilize the patient with the A, B, and C.
Okay. Thank you so much, Dr. Chong. So now maybe your closing statement for us here.
Yes. Yeah, so I want to thank Dr. Fitri again. Hopefully this is relevant to the student when they manage the patient, especially because this can be quite serious and quite emergency and very time sensitive. So within the first hour, we need to make an intervention for the patient.
Okay. Enough, Dr. Chong?
Yes,
Or
thank you,
another?
Doctor.
Thank you so much for your excellent lecture, Dr. Chong.
Thank you.
Happy Sunday, and then
Yes, thank
see you in the next time.
Yes,
Bye-bye.
thank you.
Bye-bye. Okay, ladies and gentlemen, maybe the third lecture is finished. Thank you so much for your patience and time.
Thank you to our moderator, Dr. Fitri, for skillfully guiding us through this insightful discussion. Also to our distinguished speaker, Dr. Chong Jintat, for sharing their valuable expertise with us. Now, ladies and gentlemen, please remain on the screen because next we would like to capture this special moment with a group photo on the Zoom meeting. Teruntuk tim dokumentasi diperkenankan untuk membantu dalam proses pengambilan foto di aplikasi Zoom. Terima kasih.
Tim dokumentasi apakah sudah selesai untuk dokumentasinya?
Once again, please round applause to our four speakers and moderator for the interesting presentation. Continuing our next session is the presentation of material by the fifth speaker with the topic the role of public health for saving life of older adults during disaster. We are pleased to invite the moderator for this fifth session. Please welcome our amazing moderator. Ladies and gentlemen, round applause to Dr. Faradi Saduri, Master of Health and Master of Biomedical Sciences.
Dr. Farah, the floor is yours.
Okay. Are you all sleepy now? Yes? No. This session we have a great topic with a great speaker. Let me introduce myself. My name is Dr. Faradi Saduri. I'm a Magister of Public Health and also Magister of Anti-Aging Biomedic. And I'm a moderator of this session. And I'm very pleased to see you here all and welcome all for you to this seminar. College doctors, our lovely student of Medical Faculty UPN Veteran Jawa Timur, and also all the senior high school students. Our speaker today, we have a topic session about disaster medicine, challenges and international collaboration. And the speaker is Professor Hafiz Khan, PhD. He is a professor of public health and statistics, College of Nursing, Midwifery and Healthcare, University of West London, UK. Before I start this session, let me read Prof. Hafiz Khan curriculum vitae. He is an Associate Professional Fellow at the Oxford Institute of Population Aging, University of Oxford, UK. He trained as a statistician and earned a PhD in Applied Statistics in 2006 from Edinburgh Napier University in Scotland. His work at several academic institutions, Edinburgh Napier University, and the International Institute for Applied System Analysis in Austria, and then the National University of Singapore, and then the University of Oxford, Middlesex University London, Birmingham City University, and the University of West London. And his principal research interests of population and development, including population aging, health and well-being in later life, with special focus on loneliness, multimorbidity, long-term care and support provisions. Prof. Khan has also so many research and publication books extensively on population, health and development. He has co-authored 2 books, Research Methods for Business and Social Science, 2007 and 2014. Before the presentation begin, let me inform how the presentation will be going. First, Prof. Khan will be invited to present the material, and after that, there will be a question and answer session. And for the online participant, maybe can write the question in Q&A at Zoom, and then followed by conclusion. Now, let me welcome the speaker, Professor Hafiz Khan, PhD. Good morning, Prof.
Good morning, Dr. Farah. Thank you very much for inviting me to give a talk today. And it's early morning in the UK, so I hope everybody can hear me. And let me share my slides for today's presentation. Okay, it is already shared, is it? Right. So, as you mentioned, I'm actually working as a professor in public health at University of West London. And we have a master's in public health, where the students are coming from different parts of the world, mainly the international programs we are running here at University of West London. We have about 50 students coming every semester. We run 2 semesters, one in September, one in February. So our cohorts are more multinational. And I'm also professorial fellow at Oxford University, as you mentioned. Basically, I do research in the area of global aging, understanding aging issues. I was coordinator for Asia Pacific regions, where we established APRA, Asia Pacific Population Research in Aging. So if our students want to come and visit at Oxford at any time, they can come and visit our Oxford University. So please feel free to contact me if you want to come and visit Oxford University. Thank you very much. Next slide, please. Right, so what I'm going to talk today, as you can notice, there are 2 different topics. Initially, I thought I'm going to talk about public health, the role of public health in disaster management, and which particularly for elderly people. So I'm going to touch upon little bit about it while I'm talking about disaster medicine today. Our students might be interested to know what is actually disaster medicine, how that area is expanding and frequently applying in the main core of medicine discipline. So I'm going to talk very briefly about the introduction to disaster medicine, some key areas of disaster medicine where are the areas we can play, where we can play important role as a doctor. And nowadays you can see a lot of natural disasters is coming, and we live with disasters nowadays. It can be war, it can be earthquake, it can be anything, you know. So then I'm going to talk different strategies needed to improve disaster medicine, because we have to live with disaster and we need to know how we can cope with all sorts of disasters time to time, and so that our peoples are happy, we can manage it nicely, and we are well prepared to tackle all sorts of disasters. So then implementations of disaster medicine and some case studies I'm going to share with you, because there are very successful model we can see nowadays in different parts of the world. Particularly it comes when we discuss about Japan. They're successfully managing things, and how we can learn from Japan and other countries. Perhaps Indonesia might be another country where people can also learn their experiences, and we need to learn from each other, you know. Then complexities and challenges involved in low resource settings. Mainly problem is if you are in a rich country, they are more capable of tackling these issues. but problem comes when you are poor, you live in a poor country where a lot of corruptions, a lot of mismanagements, and your public health system is not functioning well, and what will happen to these people and to this management role. Then question comes actually the international collaborations, the partners coming forward and helping. But if you have a good partners countries, they can come immediately and helping. And we'll talk a little bit about it and followed by some, conclusions. So the next slide, please. Right, so what is actually the disaster medicine? Generally speaking, it is a specialized area of medical practice that focuses on the provision of healthcare services to disaster survivors and the medically related aspects of disaster preparations, planning, response, and recovery. So you can say every stage is important for us. Right from the beginning, these people play a very important role with the rescue team, and the every stage are very important actually. When what sort of preparations do you have? Primarily, this team is working and getting ready all the time. So if anything happens, they are jumping on to this disaster site and immediately responding and recovering this. So the preparation is very important. You have to have enough resources, the people, the partners, and the medicine, and the equipments, and all sorts of things. So there should be a team and the departments who can work for this, and around the year making plan. If anything happens, training peoples and responding to any kind of emergency. They can do a lot of drilling time to time. You can see sometimes, and they can do some practice. What will happen if there is a disaster on the site? So every institution is doing it. They're educating the institutions. They are educating the students in the school, college, because our purpose is to save people's life. And that's very important, So in Japan, this is part of their job. So if anything, any earthquake happens, the office is fully trained, and they know actually what needs to be done, and they do accordingly. And it's easy to manage the office, and everybody knows actually what people are doing during a disaster, and that saves people's life, and obviously for the elderly as well. It serves the dual areas of providing healthcare to disaster survivors and providing medically related disaster preparations, disaster planning, disaster response, and disaster recovery leadership throughout the disaster life cycle. So, as I said, actually, the two sides of it, one is the healthcare side, and then another side is the providing, the training, the preparations, the screening teams, and immediate, response to the healthcare. So the specialists in disaster medicine provide insight, guidance, and expertise on the principles and practice of medicine, both in the disaster impact area and healthcare evacuation, receiving facilities to emergency management professionals, hospitals, healthcare facilities, communities, and the government. So you can see every single stakeholders are very important for us to work together in order to save people's life. So emergency healthcare management professionals who are very much trained in that area. The trained consists of local and international people because the international peoples are coming and liaising with the local people and advising time to time what needs to be done and continuously supporting the local government and local authorities. So it is a interdisciplinary team who are fully engaged with the specialist to save people's life. They engage in the development and modification of public and private policy, legislation, disaster planning, and disaster recovery. So what it means actually, the team is their main target is to say how to give emergency treatment to these people and to save people's lives so that the peoples are not suffering for a longer period of time. But they also see what sort of difficulties they face time to time. They then work together with the government to change the policy, to change the legislation. They also need the support from the police department, law and order departments, and also support from the local government. So any kind of support, either it can be the logistic support and the safety and security support, anything, because once there is a disaster, we see often the people's coming from outside and making a lot of problems. They're looting these property, making things worse, and it is difficult for us to manage the site and manage it efficiently. Next slide, please. So what are the areas of disaster medicine? You all need to know actually what would be our job when there is a disaster. So we are talking about disaster management, a humanitarian crisis quite often. So everywhere you can see this is going on. The world is very much unsafe sometimes. This it's often we see there are wars, and there are humanitarian crises, there are actually natural disasters, climate change, a lot of things are coming up. So the area will be growing, and we can see there is a big area where you can develop your career. Is called humanitarian public health area, because more and more we see we need people trained in that area. So the disaster medicine areas particularly, we classify into 3 areas where I can tell you the disaster healthcare. The healthcare is an important area. It provides, it's a provision of healthcare services by healthcare professionals to disaster survivors and disaster responders. Both in a disaster impact area and healthcare evacuation, receiving facilities throughout the disaster life cycle. So your job is to give the emergency services to these people on the side and also on the hospital and healthcare side so that people can, survive and get the treatment. And also you need to evacuate you need to be part of the evacuation team where then people can immediately rescued and get the services. So it's a long process. Some of the survivors need actually the minor treatment, others need the long-term care and treatment, and that also needs actually the big budget and planning for the country, and it's a huge impact, and particularly as you can see, when there is a disaster, the elderly peoples are vulnerable, they are affected most, and their chance of dying is high, and these peoples need the treatment, and most of the elderly peoples we see in later life are have the mobility problem, they suffer with arthritis and others, and they need the long-term care and treatment. So in that way, this has a huge planning and treatment and management at the hospital side or care management side. Then also coming to disaster behavior. No, I think the previous slide, please. So disaster behavior of health, where we see that this performs on the survivors' mental health as well, where they need actually rapid response of their needs, and some of them feel unsafe, threatened, and they lost their relatives, neighbors, and they are actually not feeling, they need to share with someone their feelings, and they need the mental health treatments as well. So the medical team can assess them, and to give them the best kind of care, and also they need actually care managements as well. On the other hand, there is a big departments who are working around the year about the planning and preparations. We see some peoples are doing it all the time. Part of the reason to do it is to educating people, making plan, telling the government. So we are doing it time to time, and so assessing the risk. So they are working and making planning if there is a flood, if there is an earthquake, if there is a tsunami, what can we do and how can we save our people, and what techniques and new innovations are coming, how can we alert people so that people can know and more people can and save their lives. So this is a department of government liaising with NGOs and others, making the preparations and making planning, training people, educating our schools and colleges and university students, and also preparing a lot of volunteers who will be playing important role when there is a disaster. And they normally assessing the public health risk, so they time to time assessing what is the risk and if there is a risk, what can we do actually in terms of planning for future disaster? What can we do in terms of implementing emergency strategies to aid recovery, and how best we can respond to any kind of disasters if there is one in front of us. So this needs the whole year preparations and planning. Next, please. So then there are many kind of conceptual frameworks or pathways how this is going to work and how these things will be working in acute care settings, particularly the emergency care service systems, where we deal with the inpatients, the outpatients, and also those who are actually the inpatients. They need actually emergency care and treatment, safety nets, and they need some sorts of immediate referral to the different departments, different units, so that there is medical services for them, and and through this kind of way you can manage the crisis quite efficiently. So we can see the medical team is playing a very important role in managing the crisis. And once you are well managing your emergency patients, and these transfer and referrals, you then these peoples are immediately get the get diagnosis and care within these hospital systems, and they get some kind of shelter and support within these temporary healthcare settings or permanent healthcare settings, or within these camps, or the established hospitals. Doesn't matter as long as they get the care and support from the communities and from the society. Then, of course, this has a huge impact on their outcome. They get immediately discharged if this is a temporary kind of treatment, and some people need long-term treatment. They need an admissions, they need a transfer to these primary care, to the secondary and tertiary care, so that somebody needs some operations, some other people's need this long-term care. Some people need geriatric care. So you can then give them a proper treatments and care, so that these people are really getting their treatments and getting cured from our system. So the system is in place where we are making sure that everything is ready for our health systems, and as a public health, we are assessing it time to time. And if there is the disaster, what will happen, how we are going to manage it in terms of scale of disaster. If it is a small disaster, it is manageable. Most countries can do it, but others cannot do it. As I said, actually in Turkey last year, April 6th, there was a big earthquake, and often we can see earthquake will be happening, tsunami will be coming, and we have to be ready for it all the time. So we need to do a lot of new innovations. We need to work closely with public health, and I see the public health can play a very important role of educating people, working with the community, working with the politicians, and this public health area has a real future, and for giving the and managing the healthcare services to the people, particularly during a disaster. Next slide, please. So what happened is not so easy when there is as disasters. We also face a lot of challenges, and some of the challenges are common to us as we get experience from the past disaster. But other challenges are like organizational challenges. These include issues related to coordinations, management of disaster and response efforts. So we need to work, mainly the Ministry of Health is working, coordinating the whole thing along with national, international bodies. And there is a huge challenges for them to coordinate and managing people. So managing thing is depending on the scale of damage. So the Turkish disaster was a big disaster. 70% house was collapsed. In Turkey, so you can see how can you survive people when 70% of the buildings are collapsed, and you need to save people's life. You need so many, manpower and equipments, and the medics. They all need to work together in order to save people's life. So it's not so easy thing actually for an organizational perspectives. So we see the coordination can save life, and this coordination can manage it efficiently. These individual challenges, this can include the psychological distress, job stress, and the health issues faced by the disaster response personnel. And some people are working day and night, when there is a disaster, they cannot maintain the schedule. It's difficult to maintain. You need to give the treatment on the one side. You can see you need to face multiple kind of challenges. Either individuals, some people are crying, and you need to give them treatment, you need to coordinate them. And a lot of, colleagues are falling ill as well, so many things are coming together. But if you get this government response in a good, if the country has a good governance, and you can see your planning and your coordination works quite well. And if you see, the country doesn't have any good governance, nobody is listening to them, their public health is fragile, you will be very shocked working with coordinating things, and you will fall ill sometimes. And a lot of people are failing. So if I can give an examples, in Bangladesh, Rohingya populations coming from Myanmar, there was a good coordination of managing, and the people were forced to leave Myanmar because of their Muslim populations, simply because of their Muslims. They are these Burmese people, but they are forced to leave Burma because of their Muslim, So in that way, you can see the team, local and international, was engaged day and night, and they also have their, psychological stress as well, because this is the immediate response. A lot of people had to move to that site immediately without any preparation. So you have to have that kind of thing. So I think this these individual challenges depending on your experience and expertise. So some peoples are more resilient than others. A lot of peoples have less training. They don't know that much. They don't may not be have that kind of interest in that, although they are doing a job in medical field. But some people's, those who are really want to take the challenges, they take it easily, and others may not enjoy the job. They might be thinking their job is very much stressful, and they want to leave the job. So there is a risk of leaving the job when there is a disaster like this. The environmental and health challenges is also the another area where the disasters often occur in environments and pose significant challenges to health, such as poor weather conditions and areas with the infectious diseases. The logistical challenges, this involves the practical aspects of disaster response, such as this procurement and the distribution of resources, communications and information challenges, like the effective communications is crucial during a disaster, but it can be difficult to maintain a reliable communications network in a disaster site because of there is no internet, there might be some other problems, and it may take little bit time because people want to know immediate news and updates, and it is sometimes challenging to some countries. Other factors like this can include a wide range of issues, such as the family concerns of disaster response, personnel, low public awareness about the disaster, and the disruptions in response to processes. So as I said, actually a lot of peoples are there to take the advantage during the disasters. So you also need actually law and maintain the law and order in order to give them the treatments. Next slide, please. So the possible outcomes challenges, like, these challenges can lead to delayed access to disaster victims, disruptions in response processes, and an increase in morbidity and mortality rates. Therefore, addressing all these challenges is crucial for improving this effectiveness of disaster medicine. The challenges can vary depending on the nature and the scale of the disaster. Some are very big disasters. As I said, the last year Turkey was a big, massive disasters in Malatya. I physically visited that site. It was not so easy, when you can see the buildings are collapsed and the roads and highway, everything is damaged. And it was not so easy to repair within a short period of time. So if you go after 1 year now, you will be able to see there is no sign of disaster, So it is only possible when there is a good government, and the government is serious to give the service to the people. To overcome these challenges often requires a multidisciplinary team or multidisciplinary approach involving not just healthcare professionals, but also emergency management professionals, governments, communities, everyone. So we all can come together and helping to each other, and that can solve our problems easily. Next, please.
Excuse me, Prof. You have 3
Yes,
minutes.
please.
3 minutes left, Prof.
Okay, right. That's fine, actually. So there are various strategies we can take to improve these disaster managements, and either you can say the enhancing disaster preparedness, and the strengthening the infrastructures, improving coordinations and collaborations. You also need actually the leveraging this technology. Yeah, the information technology can play a significant role in order to give the services in terms of telemedicine, remote care, mobile apps, and communications. So we recently can see, and the Indonesia has developed some kind of tools, which is very good in terms of communications and resources. Next, please. And we also can see there are other areas where we need to do continuous research and development, and we also need this for health policy and legislation side, how best we can work together with the government in order to save people's life and educating public. Particularly, we want to educate our high school students and college students. They are the very future leaders for the country, and they can come forward and helping to each other. Next, please. And then we see a lot of successful implementations of the projects management side in terms of the Japan's DIE framework for disaster risk management. So we also can see the earthquake managements in Japan. They are very efficient in terms of managing the sites. We also can see this Vietnam's response to COVID-19. They are an example of saving people's life. You also can see this 2023 model core contents of disaster medicines, and these are all helpful in the United States in terms of saving people's lives. Next, please. And the case studies related to these implementations, if you can go through the case studies of telemedicine using disasters, you also can see how best they can help to save people's life when there is a disaster, particularly in the United States. Health emergency and disaster risk management can also help globally in terms of savings. And you also see how best we can use the telemedicine and in terms of health. And we also can see there are other, case studies in public health preparedness and responses to these people. And next one, please. And these case studies provide valuable insights into the practical applications of disaster management and medicine principles and strategies. They highlight the importance of preparedness, coordination, and the use of technology in managing healthcare emergencies and reducing the impact of disasters. Particularly, there is one actually. Okay, next, please. So there are big challenges, as I said. There are examples in developed and developing countries, but those who are actually living in developing countries, we can see it is public health find it very difficulties in terms of operational side, because of there are a lot of there are poor good governance and poor resources and a lot of corruptions in developing country, and in that way we can see the examples of during the COVID time. It happened because the health system is not fully ready to respond, and it is difficult for us to implement when there is a disaster. Next, please. And we also can see the complexities are different than this developed country when you are working in this poor country, like financial resources. You have seen the less commitment from the government in order to helping the international bodies. We also see these the low resources, paucity of informations, and very difficult to work on the site. And we also see the infrastructures are not well adequate to help the people on the site. And And also we see these research challenges are also important in terms of getting informations, and also, the different source of data is very poor in developing country. And we need a lot of money and investment for future research for the research. Next, please. So I think we can jump on to this next conclusions. Can I just go to the conclusions, please, so that I can go. Yeah, so we need actually international collaborations in order to come together and solving this problem. So how you can make friends with your countries. For example, if it is in Indonesia, they need to think actually who will be their friends if there is an immediate threat in disaster. So the neighboring country, neighboring people will come forward, and you also need to work with the provincial level, how best they can come forward and helping to each other in order to save people's life. That's very important. International partners will give you the money to do that quickly. And next, please, I need the conclusions only. Yes, so then jumping onto these conclusions, what I'm going to say today is to give this disaster medicine is a branch of healthcare focused on assessing public health risks, planning for future disasters, and implementing emergency strategies to aid recovery. So this public health is playing very important role of coordinating clinical, non-clinical, and these different stakeholders, they all coming together. And the leadership in public health is very important. When you are a leader in public health, you know what exactly is going on. You have the good planning and preparations in order to manage the site. It is vital public health as it helps the societies plan for and manage serious dangerous situations that could potentially have a devastating impact. It is an emerging field that continues to grow in importance, and with the rise of catastrophic disasters. So if there is a catastrophic disasters, there is no way otherwise disaster medicine can help. Therefore, adequate knowledge and skills are required to tackle and manage imminent risk of any natural disaster. So we see from our discussions that the disaster medicine will play an important role in public health, where they can immediately give the treatment and manage the treatment, and also saving people's life for any kind of future disaster. Thank you very much for listening. I'm happy to take some questions. There are few references are given for you to read. The more you read, the more you will learn something. I would say actually this public health area is growing. So the more you can gather information would be better for you to understand. You also can enroll with UKMed, international agencies, and also UNHCR. I'm encouraging our students to enroll with the UNHCR, volunteering with different activities. While you are a medical student, you should do that. And those who will be coming to a medical educations, you should have your own kind of interest and you have your intention to serve people, helping people, and that will give you, a better chance to real contributions to this field. Thank you very much.
Okay, now is answer question session. Maybe some of you have a question for Prof. Khan. Okay. Because the time is limit, maybe only one question. Oke, bisa maju? introduce yourself.
So thank you for the time. Before first thing first, I will introduce myself. My name is Awanda Dias from Faculty of Medicine, UPN Veteran Jawa Timur. So for today, I will ask about how can telemedicine support public health service during disasters? Thank you.
Well, thank you very much. I think what happens, as I say, this is part of your preparation. So you need to know who can give you the help when there is a disaster. So if you know we have good connections with the UK, USA, different organizations. If there is anything happens, you can quickly ask for assistance, and they can give you some kind of assistance, technical assistance in terms of telemedicine when you need actually the advice from them. They can give you the advice. Sometimes they can be online and telling you to do this one, that one, when you don't know what to do. Say, for example, if you want to survive someone, you don't know exactly what needs to be done, but they can tell you, do this way and do this kind of treatment, and it immediately helps you. So the different teams are working online, different sorts of, and if you need any special kind of assistance, you can call them, and immediately they can help you locally. I think the telemedicine is not only working internationally, it is also a good way of communicating with physicians within the country. Say, for example, Indonesia is a big country with so many thousands of islands, and some of the doctors are living in one place, but the disaster happened in one place where there is no doctors, nothing, or not very many doctors there. So in that way, how you can connect with these people with the big cities? Yeah, I think the telemedicine can help, you can immediately take their advice, and you can send volunteers, can follow their advice and helping each other. Yeah, so you need to build the immediate communications. Once you have the communication established, you can seek for help, and that is very good benefit to the people, and our status time to time, you can ask somebody how do you feel. They can say, okay, I'm not feeling good. Then you can say, go to the next hospital nearby and don't travel anymore, and you can save people's life, if this big guy can if the guy is traveling, he can die, So in that way, the advice is helping, definitely helping to the people. Right, so any more questions?
Sorry, Prof, because the time is close now. Maybe I will give conclusion or the important statement from your presentation, because our medical faculty has a mission about disaster medicine. It is very close to what you present here, Prof. Han. So maybe I translate it into bahasa for our student. Kesimpulannya jadi tentang presentasi dari Prof. Han ini adalah tentang kedokteran bencana sesuai dengan visi Fakultas Kedokteran kita, yaitu keunggulannya adalah disaster medicine, ya, kedokteran bencana, di mana kedokteran bencana merupakan layanan kesehatan yang berfokus pada penilaian resiko kesehatan masyarakat, perencanaan untuk bencana di masa depan, dan penerapan strategi darurat untuk membantu pemulihan. Kedokteran bencana ini sangat penting dalam kesehatan masyarakat karena dapat membantu masyarakat merencanakan dan mengelola situasi serius yang berpotensi memiliki dampak yang menghancurkan. Kesehatan masyarakat sendiri juga merupakan bidang yang sedang berkembang dan semakin penting seiring dengan meningkatnya bencana yang mematikan. Oleh karena itu, pengetahuan dan keterampilan yang memadai diperlukan untuk menangani dan mengelola resiko yang mungkin timbul dari bencana alam di masa depan. Okay, maybe you have closing statement, Prof. Khan?
Sorry?
Maybe you have closing statement for us, or maybe it is enough. And for your information, yes, and for your information, it is about 4 EM, yeah, Prof, at London.
Yes,
is it right?
yes, it's very, very early morning here, you know.
I'm sorry.
And thank you very much, Dr. Farah. You send me a text which helped me to understand the timing, you know.
Yes, I'm sorry for disturbing your rest,
No,
Prof.
not at all, actually, not at all, you know. That's part of life. What can I do?
Jadi di London ini sekarang jam 4 pagi, Bapak Ibu sekalian, tapi Prof. Khan bersedia meluangkan waktunya untuk menjadi pembicara di acara seminar kita. It is a great honor for us to have you here, Mister. Maybe we can see you for the next presentation.
Inshallah, I'll come and visit you, okay?
Okay, give applause.
And thank you everyone, students and everyone, and hope to work together, inshallah, okay?
Okay, thank you so much, Mister.
Take care, take care.
Okay, MC.
Assalamualaikum.
I give it to you.
Thank you, Professor Han and Dr. Farah, for the interesting and meaningful session. Now, please, ladies and gentlemen, remain on the screen because next we would like to capture this session moment together with all of the audience on the Zoom meeting. Kepada tim dokumentasi diperkenankan untuk membantu dalam proses pengambilan foto di Zoom meeting. Terima kasih.
So we are finally arriving at the last session of our seminar for today, the presentation of material by the 6 speakers with the topic Repairing Damaged Heart, a Basic Science Perspective, with a warm invitation to the moderator for this last session. Distinguished guests, please welcome our special moderator, Dr. Aulia Fahira, Master of Biomedical Science. Let's give a warm round of applause. Dr. Aulia, the floor is yours.
Okay, thank you very much. Good afternoon, ladies and gentlemen. Welcome to the last topic of Urgency 2024 International Seminar from Faculty of Medicine, Universitas Pembangunan Nasional Veteran Jawa Timur. It's my pleasure to introduce our next speaker, Professor Delphak Osiandi, Medical Doctor, Doctor of Philosophy, a Professor of Molecular Cardiovascular Science, Division of Cardiovascular Science, University of Manchester. Let me read a brief of the curriculum vitae. Professor Delphak has been recognized with numerous personal awards, including Young Investigator Award in Basic Science from the European Society of Cardiology. His groundbreaking research, funded by prestigious grants, focuses on understanding heart failure at the molecular level and novel approaches to regenerate the damaged heart. So please welcome Professor Delphak Osiandi.
Thank you very much. Good afternoon, everybody. Can you hear me?
Good afternoon. Yes, Prof.
Is it okay to start now, or
yes,
shall I share my screen?
Yeah, you may start now, Prof.
All right, okay. Right, thank you very much for the invitation. So my name is Delphak Osiandi. I'm based in Manchester at the moment, but I'm from Indonesia. So if you want me to speak in Bahasa Indonesia, let me know, then we can do that.
The audience, do you want in English or Indonesia? Indonesia, Prof.
Oh, Indonesia, ya baik. Terima kasih. Selamat siang semuanya. Hari ini saya akan sedikit sharing mengenai riset di laboratorium kami di Manchester. Jadi saya saat ini guru besar di bidang molecular cardiovascular science dan riset saya mengenai heart failure atau gagal jantung. Tapi perspektifnya dari ilmu basic science, ilmu dasar. Mungkin ini berbeda dari pembicara-pembicara sebelumnya, tapi mungkin cukup penting juga untuk melihat bagaimana ke depan penanganan gagal jantung atau serangan jantung akut dengan melihat apa yang sudah terjadi di level ilmu dasar kedokteran pada saat ini. Jadi kenapa penyakit jantung itu sangat penting, itu menjadi masalah baik di Indonesia maupun di seluruh dunia, karena ini data dari Indonesia penyebab kematian tertinggi, semua mungkin sudah paham, penyakit kardiovaskular ya, stroke dan ischemic heart disease, penyakit jantung ischemic, dua-duanya kardiovaskular. Jadi kenapa saya sekarang fokus ke penyakit jantung ischemicnya itu? Kenapa regenerasi jantung itu sekarang menjadi topik pemikiran yang sangat penting, topik yang sangat hangat ya di bidang penelitian dasar. Karena saya ingin coba menerangkan dari sisi sudut pandang klinis dulu. Saat ini jika ada seseorang yang terkena serangan jantung akut, maaf saya coba aktifkan lasernya dulu. Ya, misalnya nyeri dada akut, biasanya di negara-negara yang sudah established, sudah maju, langsung telepon emergency, ambulan datang. Diagnosis biasanya sudah bisa dimulai saat perjalanan ke unit gawat darurat, sehingga pada saat dia masuk ke ruang ICU kalau memang sudah ditegakkan diagnosisnya myocardial infarction, biasanya sudah disiapkan intervensi ya, PCI, percutaneous intervention, langsung coba dibuka pembuntuan dari coronary arterinya. Jadi di sini sangat penting apa yang disebut dengan maaf ini kok nggak jalan. Ya, apa yang disebut door to balloon time, yaitu waktu pada saat dia tiba di unit gawat darurat sampai pembuluh darah yang terbuntu itu terbuka. Dan ini diusahakan untuk sesingkat mungkin ya. Mungkin ini sebaiknya saya matikan saja ininya. Ya, jadi kondisi ini meningkatkan survival. Di Inggris itu angkanya dulu tahun 60-an, survival atau yang selamat, yang tidak meninggal pada serangan akut itu 30%. Tapi akhir-akhir ini karena perkembangan riset dan perkembangan penanganan di fase akut, ini naik menjadi 70%. Apakah problemnya sudah terselesaikan? Jadi belum tentu. Jadi ini yang terjadi pada saat serangan jantung akut jika kita lihat dari sisi apa yang terjadi di jantung ya, di sisi seluler, molekuler dan sebagainya. Jadi kalau mulai di titik waktu 0 di sini, maka pada sekitar 20-30 menit sesudah dia terbuntu, sakit dada begitu, baru mulai terjadi ischemia, nekrosis, apoptosis, kematian sel ya. Dan ini akan terus meningkat naik pada saat biasanya pada saat reperfusi atau terapi pembukaan koroner itu sudah dilakukan, sudah ada sekitar banyak proporsi dari miokardium itu sudah mati gitu. Apalagi kalau terjadi dibuka, tidak langsung berhenti itu kematian sel karena terjadi reperfusion injury. Jadi karena terbuka ada flooding oksigen dan sebagainya, kalsium imbalance, itu kematian selnya naik sedikit, kemudian baru stabil. Jadi apapun yang bisa dilakukan pada saat akut, kematian sel tidak bisa dihindari. Dan typical myocardial infarction atau secara umum serangan jantung akut mematikan sekitar 25% dari sel kardiak myocyte, jadi sel otot jantung yang jumlahnya di manusia dewasa sekitar 4 miliar, biasanya akan hilang sekitar seperempatnya, itu sebesar 1 miliar. Dan sel jantung dewasa itu mempunyai kemampuan reparasi atau regenerasi yang sangat terbatas. Jadi biasanya jantungnya akan menjadi seperti ini. Banyak sekali digantikan oleh jaringan parut, jadi terjadi inflamasi. Setelah beberapa hari atau 1-2 minggu setelah inflamasinya hilang, tidak akan diregenerasi lagi. Jadi diganti menjadi jaringan fibrosis yang tidak bisa kontraksi ya. Sehingga fungsi jantung akan menurun secara drastis sesudah serangan jantung akut. Itu secara umum perjalanan penyakitnya seperti itu. Jadi kalau dibiarkan maka daerah infark itu akan meluas tapi akan stabil, dan daerah yang non infark yang masih sehat harus mengkompensasi akan kehilangan daerah yang mati tersebut, sehingga terjadi remodeling, hipertrofi dan sebagainya, sampai pada titik remodeling itu tidak bisa mengantisipasi kekurangan atau menurunnya kontraktilitas, sehingga terjadi adverse remodeling yang salah, jadi dilatasi, fibrosis, inflamasi masuk lagi, sehingga jantung menjadi gagal jantung. Jadi kontraksinya tidak bisa memenuhi kebutuhan dari tubuh. Gitu. Nah, ini adalah angka statistik. Kalau kita balik lagi ke terapi yang akut tadi, terapi yang emergensi tadi, apakah bisa menyelesaikan masalah? Jadi ini yang data beberapa tahun yang lalu, mortality atau kematian karena serangan jantung akut yang garis merah ini memang menurun ya. Sejak PCI atau garis hitam putus-putus ini, itu yang intervensi tadi mulai diadakan, mulai dikenalkan tahun 80-an, maka kematian akut itu turun, tapi insiden prevalence dari heart failure itu naik yang biru ini. Jadi masalahnya bergeser dari kematian akut ke heart failure atau masalah-masalah yang kronis. Sehingga kita berpikir bahwa kalau misalnya kita mempunyai sesuatu cara untuk membuat sel otot jantung itu bisa meregenerasi dirinya sendiri, maka ini akan menolong sekali untuk mengurangi proses yang patologis tadi. Nah, jadi itu adalah pertanyaan utama yang berasal dari masalah klinis. Kemudian kita akan mencoba mencari jawabannya dari sisi ilmu dasar biologi medis dan genetika medis. Jadi pertanyaannya, bisakah kita memperbaiki jantung yang sudah rusak? Atau istilahnya, can we fix a broken heart? Nah, sejarah regeneratif medicine itu bergeser. Sekitar tahun 80-an yang disebut regeneratif medicine, ini contoh dari cover majalah Science tahun 2000-an gitu. Regeneratif medicine itu bayangannya adalah mengganti organ yang rusak dengan prostetik atau dengan robotics, gitu, bahan-bahan artificial yang ditanamkan lagi. Jadi di jantung juga ada LVAD namanya, left ventricular artificial device, gitu, untuk membantu kontraksi. Ada juga pandangan bahwa regenerasi itu adalah mengganti dengan jaringan donor, gitu. Ini contoh kasus yang cukup terkenal di Inggris tahun 2010-15 gitu, keberhasilan mentransplant tangan seorang anak, dua-duanya ya, karena infeksi tertentu gitu harus diamputasi. Kemudian dia mendapat donor tangan dari donor yang lain, kemudian dua tangannya bisa berfungsi kembali seperti agak normal begitu setelah beberapa bulan ditransplantasi. Nah, jadi ini adalah pandangan yang sudah kita ketahui selama ini. Tapi bagaimana ke depannya? Riset yang akan saya tampilkan berikut itu diinspirasi oleh ini adalah satu pengamatan dari Howard Hughes Medical Institute. Kalau binatang semacam amfibi ya, amfibi itu semacam kadal gitu ya. Kalau kita potong ekstremitasnya, kemudian itu diamati secara terus-menerus, maka biasanya akan terjadi regenerasi penuh ya, regenerasi secara maksimal baik itu ekstremitasnya maupun ekornya. Cicak juga seperti itu. Jadi di beberapa spesies tingkat evolutionary yang lebih sederhana itu daya regenerasi masih sangat tinggi. Nah, jadi kita berpikir apakah itu juga bisa ada di organ yang lain, misalnya di jantung. Gitu. Nah, ternyata jawabannya iya. Ini adalah beberapa laporan riset yang dilakukan di embrio mencit atau tikus kecil yang dilaporkan beberapa tahun yang lalu, tahun 2011. Mereka memotong apex dari jantung embrio mencit, kemudian diamati sampai 21 hari bisa terregenerasi secara sempurna. Kemudian ada juga laporan sebelumnya, sebenarnya ini sudah diketahui 10 tahun sebelumnya bahwa di spesies yang seperti tadi di amfibi, tapi ini dicoba di model ikan, zebrafish, dipotong juga ujung apex jantungnya, ini 1 bulan sudah mulai terbentuk jaringan yang baru, 2 bulan sudah sembuh sempurna, jadi dipotong beberapa milimeter gitu, regenerasi terjadi sempurna. Nah jadi kita mempunyai satu teori pada saat ini bahwa regeneratif capacity dari satu spesies di organ apapun itu paling tinggi di 2 level kompleksiti fisiologis yang berbeda, yaitu di hewan-hewan tingkat evolutionary yang simple seperti ikan dan amfibi, ataupun pada di mammalians, misalnya di mencit hewan-hewan mamalia bertulang belakang dan sebagainya itu. Pada embrionya itu masih tinggi daya regenerasinya dan itu akan menurun secara pelan-pelan ya, secara tergradasi pada saat dia sudah dewasa. Jika organ itu sudah terdiferensiasi dan develop secara sempurna, maka regenerasi itu akan hilang dan itu terjadi di jantung. Maka kita punya satu hipotesis, apabila terjadi serangan jantung akut di jantung mamalia, hewan yang kompleks tapi dewasa yang tidak punya regenerasi. Tapi kalau kita bisa menemukan faktor yang bertanggung jawab pada regenerasi ikan atau embrio tadi ya, yang saya contohkan tadi, kemudian kita aktifkan lagi di jantung tersebut, apakah ini akan memperbaiki jantung yang rusak tadi, broken heart tadi? Itu adalah pertanyaan utama yang akan saya coba sampaikan pada sesi hari ini. Nah, kita di lab kami mempunyai satu teknologi yang kita pakai untuk mencoba memahami bagaimana proses development atau perkembangan jantung itu dari sejak sel, embrio, dan sampai menjadi jantung dewasa. Tapi dalam bentuk sel. Jadi kita bisa membuat stem cell dari sel fibroblast, dari sel jaringan ikat, kemudian kita program menjadi stem cell, dan stem cell ini bisa kita diferensiasi menjadi sel jantung. Ini contohnya ya, yang di sebelah kanan ini kalau bisa dilihat adalah stem cell yang sudah kita diferensiasi menjadi sel jantung yang berdetak. Tapi ini semuanya di test tube ya, jadi di kultur sel gitu, model kultur sel. Jadi ini bisa kita modelkan, misalnya ini sel dari mencit dijadikan embryonic cell yang tengah, kemudian kita jantingkan sel dewasa. Jadi proses ini bisa kita ibaratkan seperti sel jantung embrio menjadi dewasa, seperti itu ya. Jadi pada saat diferensiasi itu terjadi perubahan dari sel embrionik menjadi sel jantung dewasa, ini yang di sebelah kanan. Dan itu terjadi selama hanya 2-3 minggu di kultur flash gitu, dengan beberapa treatment atau pendekatan yang bisa kita lakukan. Ini sudah rutin kita lakukan. Jadi kalau kita bisa mempelajari ini di model ini selama 18 hari ini, dan kita cari faktor-faktor apa yang yang ada pada saat dia masih embrionik tapi hilang pada saat sudah menjadi jantung. Mungkin kita bisa mendapatkan faktor itu. Jadi itu yang kita lakukan dan kita temukan satu pattern ya, pola gitu. Pada saat sel itu masih kayak embrionik ya, yang D0 ini, maka dia terproliferasi. Ini adalah yang hijau-hijau ini sel yang sedang membelah, yang mitosis. Kemudian pada saat dia terdiferensiasi menjadi sel jantung, dari sejak hari ke-2, ke-5, ini maaf ini nggak kelihatan, ini hari 10 dan ini hari ke-15. Itu angkanya agak ke bawah itu. Ini hari 10 ke-15, maka proliferasinya turun drastis. Nah, kalau dihitung seperti di grafis di sebelah kanan, ini marker-marker proliferasi. Jadi selama perubahan sel dari embrionik ke sel jantung, itu memang daya regenerasinya turun drastis. Nah, jadi ini modelnya sudah pas, dan kita ketemu satu faktor yang kita sebut hyposignaling pathway ya. Itu terdiri dari 6 molekul yang ada di sini, dan ini aktivasinya itu terjadi perubahan. Jadi hyposignal itu yang 6 molekul yang di atas, kemudian YAP itu molekul yang targetnya yang di bawah. Itu aktivatisnya berbanding terbalik aktivasinya. Hyposignal itu 0 pada saat dia belum terdiferensiasi, kemudian menjadi positif, menjadi tinggi pada saat selnya menjadi sel jantung. Dan YAP kebalikannya, karena hyposignal menghambat YAP. Jadi ini yang bisa kita deteksi pada saat proses sel dari embrio D0 menjadi sel jantung hari ke-15, YAP activity itu turun drastis setelah 2 hari. Nah, jadi ini kita ketemu modelnya, kemudian kita bertanya, kalau balik lagi, kalau YAP activity-nya dikembalikan pada saat seperti embrio levelnya, gimana yang terjadi? Nah, itu kita lakukan eksperimen ini. Jadi yang sebelah kanan dan tengah itu YAP-nya kita kembalikan, kemudian kita bisa memodelkan satu, saya nggak usah terlalu detail, tapi kita punya satu sistem yang bisa men-switch on gitu ya, on and off satu gen gitu, dengan menggunakan satu teknologi molekul tap on tap off gitu. Jadi dikasih tetrasiklin atau doksisiklin, gennya itu langsung switch on gitu ya. Dan ini bisa terlihat dengan jelas bahwa pada saat sel itu menjadi dewasa, ini adalah marker mitosisnya hilang ya, hijau-hijaunya kecil. Tapi setelah YAP tadi itu kita switch on dengan pakai doksisiklin, ini modelnya genetik agak sedikit kompleks, tapi pokoknya naik gitu aja lah. Nah, itu langsung selnya langsung terproliferasi atau terregenerasi. Jadi kita ketemu satu faktor yang bisa kita modifikasi untuk menaikkan daya regenerasi tadi di level stem cell ke cardiomyocytes. Nah, jadi intinya kita sudah ketemu targetnya. Kemudian kita ingin mencari mana yang bisa kita aplikasikan ke hewan coba misalnya. Jadi dari situ kita harus melakukan screening dulu. Ini kita lakukan sekitar beberapa tahun yang lalu, 2015 begitu ya. Kita mencoba men-screen banyak faktor yang bisa kita target untuk menginduksi YAP. Nah, ini contohnya seperti ini. Ada beberapa faktor yang bisa kita identifikasi, dan ini semuanya kita lakukan di Manchester. Kita ketemu 4 faktor genetik ya nih, gennya ketemu, pontin, serotonin reseptor 2B, microRNA 411 sama SIG2. Nah, semuanya sudah ditemukan sekitar 5-6 tahun yang lalu. Kemudian sudah diteliti beberapa staf peneliti tempat kami, ada postdoc dan PhD student. Hari ini saya sebenarnya siapkan cerita serotonin reseptor 2B sama microRNA 411 gitu ya. Tapi mungkin waktunya nggak cukup ya, saya coba cepat-cepat aja. Serotonin reseptor itu biasanya kita tahunya kan di sel neurologi ya, di sel otak dan sebagainya, yang banyak ditarget untuk depresi. Jadi kalau depresi diaktifkan gitu. Tapi dia ada juga di jantung, dan ternyata ada kaitannya dengan YAP tadi ya, YAP dan hypo pathway itu. Jadi kita aktifkan coba di di jantung. Ini modelnya seperti di sebelah kiri ini. Kita ambil jantung dari tikus, kita kultur, kemudian kita aktifkan pakai genetik model gitu ya. Ini sebelah kiri itu Western blot sudah aktif ini serotonin reseptornya, dan selnya menjadi menyala hijau semua karena dia terproliferasi. Jadi betul, secara in vitro kalau kita aktifkan sel jantung akan terregenerasi secara cepat. Kemudian kita coba di mencit, kita coba pakai transgenik, kita overekspresikan di level transgenik itu harus dimasukkan di embrionya. Jadi overekspresi dari sejak embrio. Hasilnya mencitnya itu memang jantungnya membesar, tapi sejak lahir sudah besar dan selnya lebih banyak densitinya. Jadi lebih banyak sel jantungnya, TG itu transgenik, NTG itu yang kontrol, banyak kardiomyositnya. Jadi make sense gitu ya, sesuai dengan apa yang diharapkan. Tapi kemudian setelah kita lakukan model myocardial infarction atau serangan diikat coronary arterinya gitu ya, untuk memodelkan serangan jantung akut, mencit ini malah banyak yang mati. Yang merah ini transgenik, setelah dilakukan model ligasi arteri koroner dalam waktu 5 hari sampai seminggu banyak yang hilang gitu, mati. Padahal yang wild type atau kontrolnya enggak. Jadi kenapa kok malah jelek gitu ya? Dan kita lihat di remodelingnya yang sudah selamat ini yang enggak mati itu, ejection fraction dan sebagainya, fungsi jantungnya itu sebenarnya enggak ada perubahan gitu. Tapi banyak yang enggak survive. Kemudian kita enggak ada slide-nya ya. Jadi kita cari sebabnya, banyak yang aritmia ternyata. Jadi karena dia sudah hypertrophy, setelah diregenerasi itu malah terjadi arrhythmic complication. Maka kita coba pendekatan kedua. Tidak kita ekspresikan dari sejak lahir, karena itu membuat hipertrofi, tapi kita ekspresikan dalam fase akutnya. Kita pakai model pendekatan pakai modified RNA atau mRNA ya, seperti yang vaksin COVID itu, kita bikin RNA yang mengekspresikan serotonin reseptor tadi, dan ternyata bekerja dengan baik. Setelah diinfarkkan jantungnya, kemudian disuntikkan RNA-nya ini langsung ke jantungnya, survivalnya nggak turun. Nah setelah kita lihat ada perbaikan ternyata, LVBW ini hipertrofinya menurun, kemudian ejection fraction walaupun nggak signifikan, masih nggak karuan ini, tapi ada kecenderungan naik lagi fungsi jantungnya. Adverse remodelingnya, dilatasi sistolik dan diastoliknya juga membaik ya. Tidak terjadi dilatasi di mencit yang disuntik messenger RNA HTR2B ini atau serotonin reseptor 2B. Setelah kita lihat infarknya, bisa dilihat di sini, infark size, infarknya itu daerah yang biru ini ya, scarnya ini, itu menurun ya, terlihat bahwa banyak jaringan yang lebih tebal lagi setelah disuntikkan dengan messenger RNA 5-HT2B. Jadi terjadi tendensi, kecenderungan untuk membaik. Tapi kita masih stuck di sini, di small animal, karena kita masih memikirkan bagaimana ke depannya untuk memperbaiki delivery methodnya, bagaimana mengirim faktor ini, mengontrol ekspresinya, dan mengontrol level dari ekspresi itu. Cerita yang kedua ini beda, jadi tadi yang kita screen pertama kan ada serotonin 2B, yang kedua kita dapatkan microRNA 411. Sama seperti yang serotonin 2B, ini ada satu mahasiswa dari Indonesia di lab saya yang mengerjakan ini 4-5 tahun yang lalu. Dia kerjakan pertama mengembalikan ekspresi dari microRNA. Jadi microRNA itu RNA yang kecil gitu ya, yang 20-25 nukleotide besarnya itu, jadi sangat mikro. Kita ekspresikan lagi ke sel jantung yang sudah dikultur. Mungkin bisa kelihatan ya, ada titik-titik kuning di sini, itu adalah fluoresan marker dari marker mitosis. Jadi kelihatan naik lagi seperti yang tadi contoh dari serotonin reseptor, ini juga bisa menaikkan proliferasi dari sel jantung. Kemudian kita coba ke model animals, sudah kita pelajari dari tadi yang model serotonin reseptor, bahwa ekspresinya harus di akut ya, Kalau ekspresinya terlalu lama dari embrionik sebelumnya itu ada efek sampingnya yang mungkin kurang baik, hipertrofi, aritmia dan sebagainya. Jadi kita mencoba mengkombinasi microRNA dengan nanopartikel untuk disuntikkan langsung di miokardium dan itu berjalan baik. Kita lihat di sini sel jantung histologinya ini beberapa sudah menyala langsung setelah disuntikkan microRNA 411 ini. Jadi marker-marker mitosisnya juga aktif lagi di sel jantung dewasa. Sehingga kita cobakan di model mencit tikus yang di serangan jantung tadi itu, ini hasilnya lebih signifikan, lebih bermakna daripada yang serotonin tadi. Jadi yang pertama, yang sebelah tengah ini adalah marker hipertrofinya. Hipertrofinya membaik di sebelah kanan ya, bar yang paling kanan ini. Kemudian ejection fraction, kontraktilitasnya terkoreksi sekitar 50%. Dan infarct size, ini yang paling penting, ukuran dari daerah infarknya juga terkoreksi di mencit yang diinjeksi dengan microRNA 411 atau yang paling bawah ini. Ini kalau dihitung maka turun sekitar 50% juga. Bagaimana itu bisa terkoreksi? Maka mahasiswa saya tadi, Bayu Nugroho, mencoba melihat di histologinya, dilihat tunnel. Tunnel ini marker kematian sel ya, atau apoptosis. Kematian selnya berkurang setelah disuntikkan microRNA 411 dan KI67, KI67 ini marker dari mitosis. Mitosisnya terjadi meningkat.
Ya.
Sudah waktunya ya?
Waktunya sudah kurang 1 menit.
Ya, oke. Saya selesaikan sekarang. Ini slide terakhir sehingga ini kesimpulan kami, take home message atau take away-nya. Tadi pertanyaannya, kalau enggak saya salah mengingat tadi, bisakah kita menginduksi lagi regenerasi faktor di jantung mamalian dewasa? Jadi apa kemajuannya sekarang? Ternyata mengidentifikasi faktor regenerasi itu bisa, dan itu sudah diidentifikasi dari melihat kita mempelajari apa yang terjadi di embrio atau hewan-hewan level fisiologis rendah tadi ya, ikan, amfibi dan tadi. Apa yang terjadi menjadi masalah adalah in vivo testingnya, delivery methods, dan bagaimana kita bergerak moving to model yang lebih kompleks lagi, large animal model, model hewan coba besar sebelum ke human trial ya. Dan apa yang menjadi masalah ternyata kalau kita mengaktifkan lagi faktor-faktor regenerasi itu, bahayanya adalah ada terjadi kemungkinan hipertrofi tadi ya, nggak terkontrol karena selnya membelah lebih cepat dari biasanya, dan itu kalau di jantung bisa menyebabkan aritmia. Saya kira saya selesaikan, stop di sini. Ini anggota lab yang sudah bekerja di riset tersebut. Terima kasih, saya kembalikan ke Mbak Moderator. Monggo silahkan, saya stop share sekarang.
Terima kasih banyak Prof. Delfak untuk penjelasannya yang sangat runtut ya, dari latar belakang sampai sudah sejauh mana penelitiannya, kemudian sampai sekarang seperti apa penelitiannya. Mungkin kita langsung ke audiens, mungkin kalau ada yang mau bertanya silahkan, yang di ruangan maupun di Zoom ataupun di YouTube bisa angkat tangan. Ya silahkan maju sini.
Baik, selamat siang Prof. Perkenalkan, saya Waidudi Ambersari dari Fakultas Kedokteran UPN Veteran Jawa Timur. Baik, izin bertanya Prof. Pertanyaan saya adalah, apakah sudah ada bayangan Prof untuk uji coba ke manusianya? Terima kasih.
Ya baik, terima kasih. Kalau bayangan pasti sudah ada ya. Dan itu memang basic science itu harus ada fantasinya. Jadi kedepannya gimana? Kalau kita nggak punya fantasi ya nggak berjalan. Jadi bayangannya nanti tadi kan di slide pertama saya ceritakan kalau penanganan saat ini semua serangan jantung akut kan biasanya sudah ada kateter ya, PCI ya, masukkan kateter lewat tangan atau lewat femoral artery vein itu, kemudian dibuka pembuntuannya. Nah pada saat itu tadi kalau ingat di grafiknya itu sudah terjadi kerusakan jantung, kematian sel sekitar 20-25%. Nah pada saat itulah saat yang paling krusial kita memasukkan faktor regenerasi, tapi secara transien. Transien maksudnya jangka pendek. Jadi faktor-faktor yang bisa aktif pada saat reparasi atau fase pemulihan, penyembuhan luka itu ya, kita tambahkan faktor itu di situ. Jadi pakai kateter tadi, kalau kita bisa mengembangkan satu teknologi menyuntikkan ke miokardium pada saat pembukaan itu pakai kateter, kemudian faktornya itu kita suntikkan dengan menggunakan teknologi yang menjamin ekspresi faktor-faktor tadi tidak terlalu lama. Jadi contohnya tadi microRNA, itu saya belum sebutkan tadi, tapi microRNA itu aktifnya dalam waktu seminggu aja kalau kita suntikkan langsung ke miokardium itu dari kita observasi kita di Mencit. Jadi naik maksimum pada hari ketiga, kelima, kemudian turun lagi, hari ketujuh udah turun. Nah pada saat seminggu pertama itu saat yang sangat penting, saat kunci untuk kita mereparasi, repair the damage heart tadi itu. Dan setelah seminggu diharapkan itu sudah establish ya scar areanya. Jadi kita harapkan pada saat itu tidak terlalu besar scar areanya, ditolong oleh beberapa sel yang terreplikasi sehingga dia sembuhnya tidak terlalu parah atau bahkan bisa terregenerasi dengan nyaris sempurna. Jadi itu bayangannya seperti itu. Faktor-faktor itu disuntikkan atau diaktifkan pada saat fase akut dan harus stop lagi setelah sekitar 1 minggu 10 hari gitu. Jadi kuncinya mungkin pada saat melakukan PCI tadi. Nah, jadi kita nanti ke depannya kalau sudah ini establish, sudah kita establishkan ke hewan level besar ya, pakai domba atau babi dan sebagainya, kita akan mencoba cara bagaimana delivery methodnya tadi itu, dan itu bayangan saya seperti itu. Kalau di manusia nanti jadinya seperti itu. Terima kasih.
Baik, terima kasih banyak Prof. Delfak untuk penjelasannya. Mungkin karena keterbatasan waktu, izinkan saya memberikan kesimpulan untuk materi terakhir ini. Jadi dari Profesor Delfak Osiandi ini menjelaskan mengenai bahwa penyakit yang paling menyebabkan kematian di Indonesia nomor 2 itu adalah penyakit jantung koroner. Dan memang fase akutnya sudah terselesaikan. Namun perjalanan kerusakan jantung itu sendiri masih terus berlanjut. Nah jadi bagaimanakah jika jantung itu bisa meregenerasi dirinya sendiri? Itulah yang sedang diteliti oleh atau perjalanan penelitian dari Prof. Delfak yang disampaikan pada siang hari ini. Dan mungkin dari Prof. Delfak ada tambahan, monggo Prof.
Nggak ada, terima kasih sudah diundang dan diberi kesempatan pada siang hari ini. Terima kasih dan sukses selalu.
Amin, terima kasih banyak Prof. Delfak. Sekian untuk materi terakhir hari ini, saya tutup. Wassalamualaikum warahmatullahi wabarakatuh.
A resounding appreciation to our speakers for today, Professor Delvak, also our moderator, Dr. Aulia, for the invaluable knowledge in this session. Please remain on the screen because next we will take a group photos together to capture this special session on Zoom. Untuk tim dokumentasi harap dibantu untuk proses dokumentasi via Zoom. Our dearest guest, we are finally attaining this moment after a 3-hour past. As we draw to a close on this enlightening seminar, we would like to express our sincere appreciation on behalf of the entire Faculty of Medicine UPN Veteran Jawa Timur for each of our amazing speakers, and not to forget, also a big thank you for our distinguished guests, especially to the Dean of Faculty of Medicine UPN Veteran Jawa Timur, the Dean of another Faculty of UPN Veteran Jawa Timur, and the Dean of the Faculty of Medicine from another university.
Also, the representative of RSUD Dr. Muhammad Saleh Probolinggo, RSUD Provinsi Jawa Timur Surabaya, RSUD Grati Kabupaten Pasuruan, RSUD Sukoharjo Barat, and RSUD Dr. Muhammad Suwandi Surabaya, and the representative of Puskesmas Kalirungkut, Puskesmas Medokan Ayu, Puskesmas Tenggilis, Puskesmas Gunung Anyar, Puskesmas Klampis Ngasem, Puskesmas Keputi, Puskesmas Menur, Puskesmas Jagir, Puskesmas Jumursari, also Puskesmas Sidoarjo.
For attending the first international seminar urgency of 2024 with the theme Current Update on Medical Sciences.
We apologize for any mistake we might have made as your Master of Ceremony today. It's such an honor for us to accompany all of our dear guests today for the last 3 hours. We, as the Master of Ceremonies today, have
permissions
to excuse ourselves.
Thank you for being a part of meaningful journey with us.
And have a great day ahead. Wassalamualaikum warahmatullahi wabarakatuh.